Yeah. That's good. Holding. Yeah. No, 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 I don't think that's good. To the last one. Yeah. Yeah. Sorry? Now the issues our audio is already being streamed. So
This is Mark. Mark is already in. Should I start?
All right. Can you see me, hear me okay?
Good morning, Mark.
Hey, good morning.
Morning to Dallas. 1 second. I will start at the first 15 minutes, or I just open. You're a bit too early.
Oh, that's okay. I'm making sure all my stuff works.
Okay. I'm live. Good. So welcome everybody to our conference and demo day. I'm very happy to welcome plenty of visitors online from pretty much from Asia to America. So we will start in a few minutes with Dominic. He will introduce you to our latest developments. He will show you a bit where Medicalholodeck is going to, what we are developing here for professional and educational uses. Then we have a speech from Dr. Mark Ryan from UT Southwestern in Dallas. He will tell us a bit about use case in pediatrics. Pretty interesting. Everybody will speak about 15-20 minutes, and then there is enough room for questions, which can be asked in the chat. After Mark Ryan, we will switch. We had to switch the following two topics. We will switch directly to Galal El Sayed from New York Presbyterian, who will tell us a bit where the travel goes in medical XR in spine surgery. And after that, we will have medical XR in thoracic surgery. And Dr. Jan Arnsmeier from University Hospital in Bonn will inform us how Medicalholodeck is implemented as medical imaging infrastructure in a big German hospital. After that, we have in person our dissection master here, Dr. Evan Goldman from Penn State College of Medicine in Hershey in the United States will show us what he did to create the super stunning anatomy models from the dissection master, and let us know what is the latest, the best ways to create own 3D digital assets for high quality virtual reality. Our last talk will show virtual reality usage in neurosurgery. Dr. Markus Holling from University Hospital in Münster, Germany, will show us a case report of a cranial axe attack and explain why Medicalholodeck was useful to understand this case, or to better understand this case. So I pass on now the word to Dominic. He's the CTO of Medicalholodeck, and he is in charge of all technical developments. So he will give you a short introduction into Medicalholodeck AI, what it does, and he also will show the latest developments on RecordXR and present RecordXR Studio for a 5-dimensional XR editing. Okay, thank you.
Mm-hmm. All right, we're just setting up the presentation. That's going to take a moment. This one here. Okay, welcome everybody. It's a great pleasure to present you what's next on deck, as we call it. It's the Medicalholodeck Tech Update. So there are 100 or 1,000 things I could talk about now, what we did in the last year, what we're going to do in the next year. But since we're short on time, I'm just going to focus on 2 things. So our major contribution this year will be Medicalholodeck AI. It's in the app since January, and Medicalholodeck AI is our way of connecting AI models to segment medical data. So to go from data that is a CT scan to actual intelligent smart data with lung segments, with organs segmented, with brain structures segmented within seconds. So Medicalholodeck AI allows you to, through the click of a button, run advanced AI models on your segmentation, on your CT scan to get a segmentation, a segmented view, which we then render together with the CT scan in one 3D view. Together with that, we have developed special UI, so you can steer the visualization, you can blend in, blend out organs, you can apply transfer functions, the coloring of the segments individually per segment. That is Medicalholodeck AI, and we're extending it right now by more models and more compatibility to existing systems. Right now, you're able to segment 117 structures within seconds through the click of a button. But we've also gone to make it compatible to MonaISU, which is a collection of models by NVIDIA, which allows you to segment even more. So we're talking here about 133 brain structures, lung segments next to lobes, the pancreas, spleen, prostate, and the list goes on. What was very important for us is to make sure that we are compatible to any model. So it will be even possible to bring your own model, so train your own model on your internal data, connect it to Medicalholodeck, and get all the data you want from your CT scans. The inference can happen on the public cloud, which we have already online right now. You can try it out, download it from the website. In your private cloud, if you have data safety concerns, or even locally on your computer. Next up, I would like to talk about RecordXR, which is going to have a big impact this year. So RecordXR, for those who are not familiar, is our solution, our technology, which allows you to record your actions and your audio and your data while you're explaining something or for a lesson or examination, and then replay it within Medicalholodeck. But it's more than that. It's not an MP4, it's not a video recording, it's an XR recording. We call it MP5 sometimes, but that's just a stretch. With a RecordXR recording, you can pause a 3D recording. You can walk around while it's running or while it's paused, take the data, change it interactively. So this is not a video recording, a pixel recording. This is a data recording. It's fully interactive. You can pause it at any time, scrub forward and backward, and experience lessons as if they were told to you in the moment, over and over again, no matter where you are. That is RecordXR. Extending on RecordXR, we have developed an internal file format, which we released to the public last year as well, which is called RXR. RXR is a file format that encapsulates a recording, an XR recording, with all the data, with all the movements, with all the audio, and makes it in an encapsulated file that you can send around to people. You can upload that to a web server, you can build up your library, and it's a registered IANA file format. So RXR is gonna be a file format for the future. It's gonna be the file format for XR recordings, for 5D or 6D or multi-dimensional recordings that you can create within Medicalholodeck, but play in Medicalholodeck or even in other applications. So RXR allows you to record, store, and share recordings, including audio, data, or as we call it, data links sometimes, which gives you a much more lightweight file, which you can send around by email with a few kilobytes in size. And of course, your actions. Building on RXR, and we're talking about this the first time in public, is RXR Studio, RecordXR Studio. RecordXR Studio is an application that lets you edit RXR files. So what we see here is an export from Medicalholodeck, which ends in an RXR file, which you can send around, or you can drag it into RXR Studio. What you will get is an interactive 3D preview of your course that you just recorded in XR, and you can move around, check what is being done and said. You have an event timeline on the bottom and an audio timeline on the bottom, and you can replace avatars, for example. You can edit the metadata. You can even cut and trim. Now, let's see how that looks like. So RXR Studio lets you take an RXR recording and combine it with more recordings that you did. So that is very essential for when you have a longer session, you want to make 1 hour long lectures, that you can cut, edit, and combine them. You have multiple takes. So if you did something wrong, start over, but don't start over completely. Combine your cuts and produce one master file, which you can export at any time into a new RXR file, which you can store, distribute, or edit again if you feel like. We've also introduced RXR project files, which is a way of managing these RXR projects, so no work gets lost. If you ever did an edit and you want to put it aside, edit it again later, store an RXR project file, or edit the RXR file as well. So after editing, you get an exported RXR file, which you can immediately import into Medicalholodeck. It will contain all your changes and all your combinated RXR files. Whoop. Okay, to summarize, we have RecordXR Studio, which can be downloaded through contacting us, which allows you to cut, trim, combine XR recordings. It allows you to preview recordings and edit its metadata, even replace audio tracks for redubbing or translation. So you record your course once in English, French, or Spanish, and you translate the audio track, and suddenly you have a course that is accessible all over the world in different languages. It allows you to manage RXR projects and to export again in the RXR format, so you never get lost if you bet on the RXR format. So what's next on deck? 1,000 things. Most important, watch out for development in Medicalholodeck AI, RecordXR Studio, and the RXR file format. Thank you very much.
Thank you. Next, we will welcome Mark Ryan. Mark, can you hear us?
Let's see.
Good.
All right, the video coming through okay?
Not yet.
Okay, so let me see what camera this thing decided to use. Oh, you know what? It's because I have my. Go. Try this. Let me change something. There we go.
That's
And are we live right now, or can I test my screen share and see if it works? Yeah, I can just do it. It's okay. Are you Thomas?
yes.
Oh, okay. I just didn't know who I'd been chatting with on the WhatsApp. Yeah.
Yeah, we can see your screen.
Sure. This. Okay, so for those of you who don't know me, I'm Mark Ryan. I'm uh, the Associate Trauma Program Director here at UT at Children's Medical Center Dallas, and I'm I'm the Associate Trauma Director, and I Surgical Medical Director for our ECMO and critical care stuff. And so I've been using the program for about 2 years now, and so I've gone through various iterations of using it, and a lot of sort of bothering Christoph and Thomas for tech support things. But here, so I'm going to show you what I'm going to start with. You know, a larger use case, and then I'll go through some different cases that I do, because there's a lot of variety in what we do, and so I found a lot of different ways to apply the program to help me with planning for some of the complex procedures. Okay, and okay, so and then this is just so we had a planned delivery of conjoined twins, and this is a fetal MRI taken at 24 weeks, and so they were connected. They're omphalopagous twins. They're connected at they're connected at the pelvis. And so this is just a 60 slice MRI. This is basically just the slices that it's the maternal scan, and this is the slices that we got from the fetal MRI. So you can see, but even with that, like the level of detail that I have is pretty good. And so what I'm doing here, the thing I like about using this is that I can basically grab it and sort of whittle like you would like with woodworking. So I can sort of just in this case, you know, the problem with MRI and with fetuses in general is that they're mostly water. And so the density of the fetus and the density of the placenta and the density of the mother is all the same. So, and so what this lets me do is sort of gradually strip away placenta and things like that so that I can, so then I can kind of visualize how the twins are sort of oriented in space. And you can see that I could take the slice of the original MRI and then set my model on it and sort of and you can see my cloud of slices from all the times that I've used the transection tool. And so so then eventually the twins get delivered at around 34 weeks 4 days. They get transferred right away, and basically all we have time to do is do a quick CT scan and head to the OR because one of the twins is not viable. And so after delivery, the sick twin is going to start making the healthy twin sick, and because he was born without lungs, and so he can't you know, so he's going to start going downhill. And so what I'm doing here is this is sort of the quick and dirty version of how I do stuff. This is just the 3D slicer program, and so all this is just the volume rendering, so I can do this in about 5 minutes because I between the scan getting uploaded into our PAC system and getting a chance to look at it was maybe 20 minutes. And so I had basically that long to make something usable. And so, and this is a quick sort of detour because it'll pertain to what we do in the OR is that, you know, for a while I've been hammering my head trying to figure out how to implement some of this stuff and use it in the OR. And so I found this motion tracking camera called a Leap Motion that basically lets me wave my hand around and it thinks my hand is a mouse. And so I was then able to bring that into the OR with the twins. And, you know, basically I wasn't the operating surgeon. I was just brought on as sort of a, you know, to do this. And so you can see that we sort of plugged it into the boom in the OR, and we were able to relay this to the anesthesia side of the bed. And so that way it wasn't, it was if the surgeon ever wanted to pause for reference, he could just walk over without breaking scrub and then move the model. And so the twins were successfully separated. One of the twins was removed, part of the spine left behind, but in total, there were a lot of organs left over, but everything was viable. And this isn't by any means the only operation this kid's going to get. And so now we got to figure, now we've done that successfully and that's complete. We have to figure out what to do next. And so we have to figure out, part of the challenge is figuring out, you know, what leg belongs to who. And the pelvis is a very unique structure. So what do we do about that? And basically trying to figure out what do we assign to who, or do we have to assign anything at the moment? And that's going to be a challenge, right? And so the big use case I have for this stuff is when I have like a very complex problem. And part of the thing with the volume rendering is it lets me see all the detail that's in the scan. So now I'm able to, now that the surgery is complete, I have time to sort of go through the CT angio, which this is like 300 slices. And so now you can see the level of detail that I have in their vascular anatomy is very good. And at this point, I've transitioned over to, I think this is the Quest 3 in pass-through mode, but I'd initially tried it out in, I'd tried it out in standalone mode. But what this lets me do is now I can sort of look at their pelvic anatomy. I can look at their vascular anatomy. I can, you know, specifically to the pelvis, I can slice the rest off and sort of look at this like there's 3 iliac crests. And so that's going to be challenging for an orthopedic surgeon to sort of sort out, you know, where do I go? Who gets what? Do we remove anything at all? Or, you know, so it's a complex plan. And so, and then once I brought that to the operating surgeon, you know, basically he got excited. So the next thing I did was, set up a group session. And I'll go into it later, but I have 3 Quest 2 headsets and my own Quest 3. And so this is the view from the fellow who's using the Quest 3 headset and pass through. This is standalone mode for her. And meanwhile, there's 2 Quest 2 headsets that myself and the surgeon are wearing, that Dr. Pandya. And so this is what I'm seeing in my Quest 2. And I sort of prefer the black void to give me some contrast when I'm looking at stuff. And so you can see there's the operating surgeon there, and there's me, and you can see our hands working together. And so basically I can delineate structures for him. He can show me what he's interested in or what questions he has, and I can do my best to sort of help him see that. And then eventually they get the hang of it. And we have the pediatric surgery fellow. I don't know if, you know, she's a very industrious, and so she's busy working on her presentation about this while she's working with us. So this is a different kid. This is a congenital pulmonary airway malformation. And again, this is me doing my whittling. And so the same deal, right? I can highlight air. I can highlight, which lets me, whatever structure I'm interested in, I basically say, what color is it? And I turn that one way up, turn the other ones down. And so then I can remove the ribs overlying it. I can remove because what I'm interested in for pulmonary malformation is the vascular anatomy, because I want to see what vessel is supplying this middle lobe, so that I can, when I'm intraoperative, I can sort of just know where to look and where to look out and to avoid that vessel. And so, and then also this is, you know, the other thing that I can do is I can use the mesh generator, and I can look and basically create a segment. So I have other programs that I can then import that into, or I can look at it, or I could print it and things like that, which I do print on occasion, but not necessarily for operations. And then, so this, and an additional use case, you know, I had a sternal tumor, and this is a plain CT. So this is a non-contrast CT scan, and subsequent MRI, because what I was interested in is this dumbbell-shaped tumor that's in the sternum, is it connected to or invading the heart? And so what this let me do is, now I'm not limited to coronal sagittal views, and I can orient it however I want, and I can basically determine that it's not stuck to the heart. It might be just adjacent to the pericardium. And this is another use case. This is a big endometrial tumor. This is a uterine tumor. And so now what I'm doing is, you know, the vascular supply to that is very complex. And so what I can see the wispy, tiny perforating vessels coming off the internal iliac artery on either side, and I can sort of plan my approach and know that those are going to be there. And so that's the main part of the surgical stuff. And so I just wanted to get into real quick the learning aspect of what I've been doing. And so in this case, here's, you know, so I'm basically structuring a liver module for my medical students. Okay. And so so I have my plain cartoon anatomy, I have my Medicalholodeck, my CT scan, and then finally I have a cadaver. And so what I realized quickly is, while teaching, is that if you put all this stuff in the same room at the same time, it gets kind of crowded. And so I'm refining my kind of lesson plan as I go. But at the very least, I can show the student, I can point out structures, they can point to things they want to know about, and then I can sort of work backwards from there. And honestly, at this point, I don't really need a lesson plan, or I don't need to pre-record these, although I might eventually, because I can only do 3 students at a time. But the main thing is that I can review all this stuff and provide multiple 3-dimensional versions of it, because this was very challenging for me to learn as a student. And so I try and think of what the hardest stuff is for me, or what was for me, and now I can sort of help them understand more quickly. And so, and for general surgeons, an inguinal hernia is like the hardest thing ever. So what you don't want to be presenting a hernia at your morbidity mortality conference, because the anatomy is extremely complex, and the old guys have been doing this forever, and they'll give you questions till the day you die. So for students, what I can do is that this is a male pelvis and a female pelvis, and so you can sort of look at the underlying anatomic differences, and you can compare that to the cadaver data. And scans aren't great for inguinal hernia, so I don't include that here. But you can see where I drew on it and looked at stuff, and then they can grab the model and they can ask questions, and so that part's very helpful. But eventually I'd like to I'll preserve these lessons, and if they ever buy me some more Quest 3 headsets, I'll put those around the med student areas so that way they can sort of reference those at their leisure. And there's some stuff so like, for example, that kid's the twin segmentation, so I purchased a spatial display, which is like a stereoscopic monitor that beams an image at each eye, because I'm still working on the problem of what do I do in the OR, because I don't want to wear a helmet in the OR. And so what these displays do is it sort of tricks you into thinking this image is in front of the screen. And so that part, so that's my OR solution, but right now mine's only 15 inches because that's the only one I could afford. And so my usual plan is I buy the cheap one, and then or the cheapest one, and then I have the university sort of, I take that to the university and try and convince them to buy the expensive one. And then these loops, these are just announced, but they were mentioned to me by a person from 3D Slicer, and basically they're just relaying a stereoscopic camera feed. And so if that's a possibility, or just think if it works, because all this technology you don't know if it works till you look at it. But yeah, so that, so these are things that I'm kind of excited about using in the OR, but for my planning purposes, I've been very satisfied with using the software so far. And I think I have a lot of places that I can take it into the future, and the pass-through thing has helped a lot in terms of solving issues with the group work, because I can point to structures and they can see me, and it's very, very helpful. But in the meantime, I can continue sort of teaching the students and planning for these complex cases. So my presentation is relatively short, but I wanted to leave time, make sure I answered everybody's questions, and I'm excited to see what everybody else is doing, because I didn't make any of this stuff up, so I always kind of assume that I'm at the back of the bus and catching up as I go. But thank you for your time and attention. I appreciate it.
Thank you, Mark. Do we have some questions from the audience? No.
Can I? Mark, one question here. Thank you for the great presentation. It was very interesting. What would you like to have as additional features on the software, on Medicalholodeck, or what would really make your life more easy?
I think the segmentation stuff is like the manual segmentation. The auto segmenter I get, but the problem with the stuff that I do is, like, so for example, the twins, like the AI is not going to know what to do with that. And a lot of all those models that exist, I don't know why I'm so blurry all of a sudden. All those models that exist, they're trained on adults. And so, for things like liver tumors and things like young kids, like 2-year-olds, and we have big renal tumors called Wilms tumors that we get in like 2-3-year-olds. And so it's a lot to ask from the AI a lot of times, because I do run the total segmenter program pretty often, and with sort of mixed results on these guys. For the bigger kids, it works out pretty well. But what I'd like is sort of like an expanded tool set for manual segmentation. And I've used the Elucius program, and that implementation is slick, but it's not but at least in my brain, for visualization, the volume rendering contains all the information that's in the CT. So the level of detail that you get is the scan. And so whereas the segmentation, having made my own for a long time, is there's always some degree of artistic license, whether it's through the AI or through me sort of cleaning it up or whatever. Like, it's not nearly as precise as what you get from the actual scan itself. And so what I tend to use those segments for is like in your your video you showed earlier is I'll take my segments and I'll make them semi-transparent, and then I will take the volume rendering and maximize the amount of complexity and things like that to that particular region. And then I can, basically have a roadmap or landmarks that tell me where I am in space and where I am in the patient, but at the same time get to look at things like vascular anatomy and complex structures within the patient. And I don't know if an AI is ever going to solve that unless, and I've already gone to the COG, which is our oncology group, the children's oncology group, and because there are some repositories of those particular conditions. And so I don't know, I'm not a programmer, I don't know anything about, but I watched, other than watching YouTube videos, this is sort of how I figured out how to do most of this stuff. And so but there's the Monai program you mentioned seems pretty straightforward for teaching it stuff or teaching it different use cases. And so if that becomes a part of the deal and I don't have to do it, then I would be super thrilled about it. But if but I'm prepared to try and struggle my way through it. But every time I end up on a GitHub, you know, repository type thing, I get sad because I'm not good at it. And then I'm reading like developer instructions and like that programming font, and it just like hurts my soul. So I try not to do that. But yeah, that's the first thing I do is figure out, did somebody else do this or can somebody do it for me? And if the answer is no, then I got to start digging through developer pages, and I don't enjoy that very much. Yeah, so that would be my main thing is manual segmentation tools. And then I think teaching wise, I'm still sort of working that out as I go. And so the challenges that I've faced so far, a lot of it had to do with the Quest 2 and not having pass through. And so what I would run into is that me and two other people would log in, and all of a sudden I'm 30 feet above that person, and then they're both below me, and then I gotta find the hotkeys on the keyboard and like walk my way down so that we can all be on the same level and like line everybody up. And so that part goes away with the pass through. And so uh, that is a problem with a solution that's relatively straightforward. But the remaining part, I'm interested to see the recording capability and stuff like that, because that's my plan. Is eventually I'm going to try and talk them into getting me fancier headsets, and then I can pass off these Quest 2 units on the med students, and they can just have it at their little station and pick it up and put it on, and sort of whenever they get downtime between cases to review things or learn stuff. Um, and it's very directed, so it's not just like a basic anatomy lecture. It's sort of we're going to do a cholecystectomy this week, and so here are the relevant structures you need to know, and here's the approach that we take, and all those things. And so that version of it makes sense to me, and it seems like it helps the students so far. But again, I'm not too far into it. But eventually, it's the university hospital, so eventually I gotta like quantify and write papers about it and all that stuff. But so far not yet.
Thank you. Evan, you had a question?
Question. Do you feel, can you hear me?
Yeah, I can hear you.
Okay, do you feel there's a difference in how well the headset handles CT versus MRI scans?
In terms of, some of it has to do with the presets, because so when you log in, you're given maybe 5 or 6 presets, right? And so then they're very non-specific. It's like Medical Holodeck 2021, Medical Holodeck 2022, and then a grayscale and an inverse grayscale. And so, and I've for each case, I will futz around and sort of change colors and make my own sort of preset for that particular thing. And I've looked somewhat at the website in terms of like naming them and cataloging them and stuff like that. But so in reality, what I need is I need a preset that's sort of liver, and it's not like there's just an MRI, right? So there's like T1, T2, there's different ways they spin different ways they spin the machine or whatever. And so there's all these variations in it. And so the presets in my, at least when I end up doing them, and tend to be relatively specific to that kind of scan. And so it would be something like a liver, like a T2 phase liver with contrast or something. You know what I mean? Like, so it but I don't know if you have to get that specific. It might just be just sort of like for liver with contrast, or lung scan, or whatever structure that, because they direct their contrast, and they tune their scan based on the structure you're trying to visualize. And so in terms of whittling that down, like by structure or by probably not by intention, but at least by an anatomic region, sort of makes more sense. And at least then, even if I got to modify it, I have a starting point, because that part takes a hot minute to sort of come together before I can sort of see the things I'm looking for. So like that, honestly, the CT scan, the with 300 slices was less work for me than the 60 slice MRI, just because you're kind of you have to polish it a lot to see the things you want to see. And so yeah, I think that's the main thing, is the preset implementation. But in terms of like, does it run well and does it work? Like it seems like it works fine. But otherwise I haven't had too many issues with it.
Do you have any other questions or from the audience?
Let's see.
Good.
Oh, I do have a chat. Oh, okay. Yes.
We had some remarks from Dr. Fabio Reina.
They were just saying nice things.
But okay, good then. But thank you so much for your very interesting presentation. And have a great day to Dallas.
Okay, no, thanks. I'm gonna try and tune in as much as I can, but I'm on call, so I'm only wearing the top half of my business outfit right now because I gotta go and do surgery stuff. But no, I appreciate you guys. You guys have been great in terms of me pestering you with assorted questions, and especially the group work aspect of it. Trying to set that up in a big hospital is challenging, just because of networking things. And so in terms of what I settled on is just like, there's a dedicated router in my office just for this, that can set up sort of a high speed, high bit rate thing to each headset that doesn't talk to anything else in the hospital, just me. And so that part took like months of, and I'm not a networking person either, so I don't know anything about that either. So like so that, but in between, like any issues I ran into, you guys have been great with troubleshooting, with helping. I appreciate it.
Thank you so much, Mark. Thank you for presentation, and wish you a great day.
All right, you too. Thanks.
We switch directly to
New York.
to Galal El Sayed. He joins us from New York Presbyterian, but I think Galal, you introduce yourself. That's maybe the best.
Yeah, so I'm Galal Sayed. I'm a neurosurgeon at Weill Cornell Medicine and adjunct faculty at Columbia, part of Ox Spine. I wanted to thank you guys for this opportunity to present, and I'll talk a little bit today about spatial computing in past, present, and future in spine surgery, basically. So I'm a neurosurgeon by training, but a spine surgeon by fellowship, and that's what the majority of my practice is. We'll go through this relatively quickly, but because you guys have gone through multiple presentations now, they've kind of covered a lot of these bases. But obviously, what I'm trying to do is cover here education, planning, the intraoperative phase, the patient experience, and then postoperatively where this plays a role. You have to forgive me here. Screen sharing is stopped. Let me see why. Sorry. This presentation I have here I built is like 3 gigabytes, so it occasionally fails here and there. So I appreciate your patience. Here you go. So let's see if we can get this to work. Yep, there we go. And that's on a 3090. So if you ever thought about it, there's an education. We're going to cover education, planning, intraoperative, patient experience, and after surgery. We'll go over education quickly. What I'm going over here is what I think. I've scoured this field. I've been using virtual reality since Oculus DK1, but really, really got into it with the Valve Index. I've been using it pre that era too with Google Cardboard. In 2015 was my first interaction with it, really. So what I've done is I've kind of scoured and talked a little bit about what I think the cutting edge of each one of these topics are. So from my perspective, teaching anatomy, I truly feel that the Dissection Master XR is the cutting edge there is out there. And I heard Mark talk a little bit about that, and don't want to beat you to death with it, but and then there's this entire concept of simulating pedicle screws, meaning the pedicle in spine anatomy is the bony corridor that we need to put screws down. Slicer 3D is kind of not necessarily cutting edge, but it is an example of how people practice placing pedicle screws. And you can see here like a Windows mixed reality kind of system here, placing a pedicle screw in blue down the pedicle of the spine vertebra. This is one of the more challenging things. This is what we use navigation for as spine surgeons, to be able to do this. Now, the cutting edge truly right now, I feel of showing off this kind of anatomy and for pedicle screw planning and simulation is really Metavis's platform for placing these types of screws. They've kind of mimicked exactly what Augmetics is producing in the augmented reality domain as far as user interface is concerned, including these green rings to allow you to kind of determine distance and target and to get an idea of where these screws should go in the spine. As far as haptics are concerned, the cutting edge right now is Fundamental VR with their haptic system mimicking like a cauterizing pen, like a Bowie, for example. But in reality, the system this is the device right there. The system is still not where it needs to be for excellent education purposes, but it's a good starting point. The future of education, from my perspective, is a virtual reality compendium, much like an atlas. Think like there is a neurosurgical atlas that we have online that was done by Aaron Cohen-Goodall, a great neurosurgeon from Goodman Campbell in Indiana, and the AO Spine organization, which is based out of Europe. We each have compendiums. I'd love to have a compendium like that in virtual reality. Finally, the real reason is because lower middle income countries need to subspecialize in things that they can't train in. So virtual reality is an excellent way of at least giving these experts in other countries additional training or additional insights before they go perform a complex surgery. So I think something is better than nothing in that regard. And this is a pretty sizable something. In the world of planning, in spine, what we really focus on in spine is fixing people that have spines that look like this. They've been fused in a flat back kind of deformity. Their head is forward. They're not able to actually stand upright. So we have to bring back their spine to this blue curvature that you can see here with a program we call SurgiMap. Inside this program, we have all of the hardware and instrumentation we're going to place and automate basically to give us an idea of what are the best bony cuts, what's the best grafts to put in, what are the best parameters to reach to be able to get this person to stand upright again. So this is what we do for scoliosis and deformity surgery. SurgiMap's been a great tool for that. We'd like to have in the future a SurgiMap completely in virtual reality, taking into consideration the 3 dimensions of the spine. We have some evidence already from the early days of this, using Google Cardboard, that using virtual reality planning for scoliosis reduces OR time, it reduces blood loss, it reduces hospital stay, and increases satisfaction for the surgeon. And this was a paper produced, I think, out of Spain or Italy. So my view of this is, this is the type of pre-surgical planning I do at Ox Spine, and I'll play this real quick. It's a 2-minute video of what I've done.
We will start with an axial CT cut demonstrating the hardware decompression.
Can you guys hear that, by the way? When I play that? Okay, perfect.
We'll rotate to a coronal cut. Demonstrates the L2 to L5 hardware and pseudoarthrosis. Using tissue filtering mode, we can see the soft tissue in red, the bone and hardware in white. Placing the patient in a right decubitus position with left side up, one can note when the psoas is translucent, the L2 to L5 disc spaces are visibly seen. In the coronal plane, one can see through the bifurcation of the aorta, bifurcation of the iliacs and the psoas, and note that the L4-5 disc space is not available for an anterior approach. Placing the patient again in the right decubitus position, left-sided up, one can note that the iliac crest is about 8.5 centimeters in trajectory away from the L5-S1 disc space and is available for a lateral anterior interbody fixation. We will now point our attention to the post-operative 3D model. After using this approach, we have the post-op model here demonstrating the L23, 34, 45 lateral interbody fixations, along with the L5, S1 anterior hardware placed from a lateral A-lift position. In the sagittal plane, one can note the hardware in blue. Now grabbing our pre-op model and using the same tissue filtering effects, we can place them side by side and note the change in lumbar lordosis from 40 to 54 and almost 14-degree correction with similar sacral slopes. One can also note posteriorly the difference in decompression, in addition to the difference in hardware. Using a technique called edge filtering, one can eliminate the soft tissue and bone on both models and demonstrate the difference in hardware. We will start.
So that was a,
We
let
will
me see
start.
here, sorry.
We will.
So that was a patient that came in with spinal cord compression and previous fixation that we corrected, as you can see in that example. Another example of a good case that we were able to present and work on with Medicalholodeck was this case here, where the patient here on the left came in with this kind of horrible deformity from a post-traumatic fall and was cemented. And this is the post-operative here on the right. Where this was really helpful was I was able to take the CT scan and filter out the spinal cord in the MRI and then superimpose the CT and the MRI with each other using landmarks. What that gave me is you can kind of see here in the very bottom of the dent in the spinal cord there. And so I could see where I'd be able to decompress the bone with the most space, because in neurosurgery, you know, our famous saying is a millimeter is a mile, right? And for the Europeans out there, a millimeter is a kilometer. Okay, so the point I'm making here is like, it's a very, very unforgiving field. So even this little bit of information here that comes with a CT to MRI merger makes a big difference in our ability to actually operate. And I found it very helpful for that case. I won't belabor this. You guys know about the AI auto segmentation package. This has been, what I'll say on my part is it's been very accurate at counting spine vertebra properly, even in weird situations with traumatic fractures. I think it's invaluable as far as thoracic counting is concerned. I still have fiducials placed by an interventional radiologist, or I will count myself in the operating room, but it's good to have that additional amount of support while you're analyzing your surgical plan. The future here is an integrated global alignment system. What I mean by that is we need to assess the angles of the spines for correction automatically in virtual reality and be able to plan derotation, plan correction of the spine in virtual reality. The next piece, or the most near future component for planning, is we need VR-specific radiology protocols. We have something called stealth scans that are thin cut scans for brain tumors in neurosurgery. We need dedicated radiology protocols for idealized VR scans. And there's a few plans there when it comes to neurography and using thin cut T2s for giving us excellent information on CSF signals with nerves for both peripheral nerve and for the central nervous system. So that's something that I'm continuing to work on as well. You know, as far as the intraoperative world is concerned, this is what we do right now is, you know, the cutting edge of the world is Larry Lenke at Columbia, who's one of our senior partners and the surgeon in chief. This is him right now planning his surgery, looking at a 3D printed model, right? So from my view, you know, and we do a lot of different things to try and get the information we need. For spine, we get full scans, which is EOS scan. We look at formetrics, which is a topical analysis of the body before we operate. We have robotic assistance. We have intraoperative CT scans. We have spine models, like I just showed you. There's a lot of things, but the fact of the matter is, the most valuable component of this is the spine model. I can't really plan where my screws are going to go, what my correction is going to look like, without getting a very clear stereoscopic 3D view of exactly what the spine looks like. It's a very visual and very three-dimensional and stereopsis-based operation, for sure. The cutting edge of what we have in the operating room right now is a platform called Augmetics, specifically for our spine performance. Augmetics is a lot like this capability of being able to place these screws, like I showed you before with the Metavis system. This screw placement, what you'll have in your AR headset, and I use this at Washington University in St. Louis during my fellowship, is it allows you to place the tap into the pedicle, just like you can see here, with a navigation system and then switch that out for a screw. It's nice, but it's not that much of an upgrade from having a monitor in the room, but it's a good initial trajectory for showing people and showing spine surgeons that screw placement can be done with augmented reality. If you look throughout the history of neurosurgeons, we are traditionally at the cutting forefront for whatever new technology is concerned, both in the world of neuro-oncology, radiation therapy. This is what our focus is, and this is no different, is having a cutting edge kind of new approach. We already have proof, and we've shown tons of evidence that these AR headsets are actually very accurate at placing screws with rates that are of 98% above. So as far as the current cutting edge we're doing at Cornell, we plan certain bony cuts that allow us to get spacers into the disc space to allow to heighten people's spine vertebra from one to the other to try and decompress the nerve so they have less pain. What we do right now is we have AR injections done through the microscope. And one of those examples is here. That circle on the right side is the pedicle. We want to drill off the joint right above the pedicle. Well, that microscopic injection tells us exactly where to drill. Without that circle, you kind of have to tug an instrument underneath that bone around the nerve and around the spinal cord, around the spinal nerve roots, and be able to feel that pedicle and then come up and decide where you're going to drill. Sometimes you're right, sometimes you're wrong, but you can always fix it. But at the end of the day, this makes the surgery smoother, more efficient, and safer for the patients if we know where these anatomic landmarks are with augmented reality. We've already shown this as far as evidence is concerned in a randomized controlled trial that immersive preoperative virtual reality training shows that there's improved satisfaction with the surgeons. There's lower preoperative stress and preparedness. Oh, sorry, let me just, again, that 3 gigabytes gets me here and there. Let me just pop it back open. Let's see here. Right. I'll just run back to where I was here. We're an intraoperative. Yep. So just to bring up what Mark brought up, I also am excited about this concept of new loops. They are a new product that were presented earlier this quarter, and they're planned for Q2 2024. The entire concept, I think, is really the correct form factor for our field. We're looking for zoom, we're looking for an augmented reality injection, we're looking for a non-obstructive view, and we're looking for something that has stabilizers in it with very high accuracy. So I think this is the right direction. I don't know if this is the right product, but I know this is the right direction. Now, I want to also bring up a quick company that went bankrupt just a year and a half ago that had an interesting idea. This is a company called Surgalign. Their interesting concept was to operate underneath a quote-unquote portal or a translucent piece of glass, essentially, where you would operate above this piece of glass and be able to see the spine from below. And they had a relatively decent anatomy segmentation platform, even though based on a poor data set. So I don't know what it was going to do really in a real life example, but as far as their models are concerned, it did a good job with segmentation. But that went through bankruptcy proceedings and was purchased, I believe, by Augmetics most recently. But it's an important and interesting concept because, to the future, I really think the future of this platform is holography, truly. I won't go through the Vario XR3, seeing I assume everybody's familiar with it, and it's a virtual teleportation concept, but that concept is very important for being able to bring a master surgeon into a room in a lower middle income country or across the country for training as well. Now, on the patient experience end, where I think there's a large room for growth in the early phases here of the use of spatial computing technology is informed consent. Patients really don't understand the surgery we're going to perform. And we have evidence from randomized controlled trials that show, hey, these patients get objectively better comprehension when they're being taught about their anatomy in virtual reality. And that's important. I mean, in addition, patients also you can use virtual reality in meta-analyses we've shown here for acute and chronic pain control as a distracted mechanism that favors virtual reality across multiple studies. The other component is using virtual reality for rehab. Physical therapy and rehabilitation for patients with cerebral palsy or balance difficulty shows that there's improvement in their neurorehabilitation by using virtual reality technologies. So this is not as most quote unquote serious physicians think of it as gaming, it really is it really is a big change in the way that we can treat our patients as a holistic approach. So the future here, as I see virtual reality being augmenting physical therapy post spine surgery, I also see that there's going to be some form of gamification or benefiting or showing the patients that they're being rewarded for learning about their surgery beforehand. We have another example of that with that study as well. So as far as after surgery is concerned, what do we really need? We need the ability to assess our patients in 3D. We need to be able to have the correction, do the surgery, be able to get an x-ray like you're seeing here that's in 2 different positions. And this x-ray reconstructs their anatomy into a 3-dimensional model using stereoradiographs. This is one company that's able to do this, but I think this concept is the future of being able to understand the human spine after we've operated on it. Did we get the correct lumbar lordosis? Did we get the right angles we needed? Did we get them looking upright again? And a lot of that you can see in clinic right now just by assessing the patient, but some of that is more subtle than it seems too. The final piece of the puzzle here is spine healthy, and this concept, what I want to show about this is there's going to be an adjunctive piece of technology that comes not from the spatial computing realm, but from the realm of smartphones still, where we still need to do recovery tracking, telemetry, and achievements based on patients' quality of life, their leg pain, their opioid intake. And this is the group that's been pioneering this kind of an app, the Endoscopic Spine Research Group, which we're a part of. But this kind of application is critical for being able to track your patients outside the clinic, and I think that's the other longitudinal component here. Not to end too quickly, so just to show one last time here, let me just share a screen one last time. Here we go. Right. Sorry. Again, managing I think I've learned my lesson as far as 3 GB PowerPoints are concerned. Let's see here. Okay, so let me present from here real quick. So what I work on specifically is, I'm working on my desire to work on these specific things that are marked with colored circles. I work on building the integrated global alignment in virtual reality, VR specific radiology protocols, the use of the RecordXR3 to help with other surgeons globally as we do mission trips to Tanzania and other places across the world. Telemetry in VR, I'd like to be able to store all the VR scans that we have for machine learning approaches and eventually build a foundational model for preventing complications, predicting deformities, predicting corrections using a VR or a 3-dimensional data set, essentially. So with that concludes my presentation, and I'll take any questions. Thank you guys so much for the opportunity to present, and I appreciate your patience.
Yes, we have one question from Mark. Any experience with looking glass holographic displays or the glasses 3D monitors?
Yeah, so the glasses, no, I don't have any personal experience other than the stereoscopic TVs that we've used, kind of similar holographic displays in the past we've used for endoscopic approaches in the skull base. And that was really popularized by UPMC in Pittsburgh and used at multiple institutions. And we have like these very large stereoscopic displays, but you have to use glasses for them. Now, the glasses-less 3D monitors, I think Samsung just presented at CES a new version of that uses eye tracking for maintaining 3-dimensional views. I think that is there's a real potential for that technology. I think there is a real potential for that. I think superimposition of holographic displays is far into the future right now, but I'm definitely excited by that promise.
Oh, sorry, I wanted to ask an additional question, or just sort of, so the spatial, or what, I don't even know what to call it, the glassless 3D monitors. So I actually bought one. I bought it. It's called the Acer. It's made by a company called Acer, and so and it's all very, very new first release stuff, and so it took a lot of fiddling with to work, but that's in terms of stuff you can bring to the OR. The only catch is that only one person can look at it at a time because it directs the image at each of your eyes. And so, but it's very compelling, but you have to have segmentation. And so I haven't figured out quite how to implement that using volume rendering and stuff like that. But I can only recommend looking into it, because if you do, because spines and bones and things tend to be relatively easy to segment, and so if you need I think you can probably get an excellent image by using it. So I would the holographic one, the Looking Glass, I only have the tiny one, so the resolution is kind of terrible, and so and the larger versions cost the I think it's the 65 inches around $45,000, so that's above my station. But yeah, those were the two, because I refuse to wear goggles in the OR, and so the those seem like the two best ways to implement that. And if there was a way to take this software and sort of project or sort of connect to that sort of technology somehow, then I think that would be sort of the best case for me, at least. But yeah, no, this is an excellent talk. I appreciate it, and I had no idea the overlay stuff and the things like that you're describing for the spine existed. So it's been awesome. It's great talk.
Thank you. I appreciate that. And I appreciate your advice and perspective. I've been acutely watching that market, but I have not taken the plunge like yourself. So congratulations for doing that as an early adopter. I'm looking more for a, I don't mind wearing loops in the OR or some kind of headset, essentially. But the difficulty there is I would like the ability to have zoom and loops and not just a heads-up display like Augmetics has. So that's my goal for my future operations.
Do we have questions from audience?
Okay, so we have a question from Cynthia. She's asking about your experience when implementing a VR education, or how did it go to implement it into your environment, like the virtual reality setup? What are the biggest difficulties?
Yeah, education is difficult because we don't have a clear spine dedicated platform for practicing different spine techniques. We do have a little bit. We have some from the big companies like S2AI screws with Medtronic. We have some with Precision OS, and also VR, and some other programs for that nature. I don't really teach medical students at this stage. I'm working mostly with residents and fellows. So the dissection master is of some use at times, but really the key education components comes from loading up a DICOM scan in Medicalholodeck and teaching people about what the goals of the case are, right? So we're looking at patient-specific information, and I'm projecting it onto a video and showing them exactly what I'm doing in virtual reality. Some of the challenges are just getting hospital buy-in, IT buy-in. It's all the kind of typical issues that come with the IT infrastructure that are the major challenges. As far as education is concerned, I feel like it's done an excellent job showing the anatomy for that patient-specific case, but I can't really put in grafts or screws or correct or look at my angles or do any of the things I need to do that I would do in SurgiMap in virtual reality. And that's something I'd like to be able to teach residents and fellows as we go forward, the goals of a correction for scoliosis correction.
Thank you. Another question from Mario. You showed the video with the 3D printed spine. What are the advantages of printed spine and digital versus 3D digital spine? And where do you see the differences also, or the advantages also for the printed model?
Yeah, the printed model shows you to some degree scale more appropriately. So you get a better idea of how something looks and relative to your reality, right? So scale inside virtual reality is a little difficult. You'll have to find some kind of idealized scale to give you an idea of what that vertebra size really looks like. For me, it doesn't affect me too much with a physical model, but I personally prefer virtual reality for everything because I can see through the model, right? So the great difficulty of a 3D printed spine is I have to rotate it, just like Dr. Lenke was showing you there, all around to get an idea of what the 3 dimensions look like. In virtual reality, I can just use the cut tool and cut through the image like it's a CT, and that'll show me the cancellous channel of the pedicle where I can place screws, or it'll show me different pieces of information about the vascularity of the nerves nearby that I can't get from a 3D printed model of bone. So I think the advantages of a 3D printed model are limited compared to what I get in virtual reality.
Okay. One question from Tom. Can pass-through technology overcome regulatories in navigation?
Say that one more time.
Can pass-through technology overcome regulatories in navigation?
No. So I think the FDA has been very specific about non-obstruction in the OR, right? So I don't see them hesitating on that. Like I think we've used exoscopes, microscopes. You know, you can make the argument that the microscope is obstructive, I suppose, and try to make an FDA argument. But from my knowledge of augmetics is difficulties getting through FDA approval for intraoperative use and surgical lines, they're very clear about it needs to be non-obstructive. So pass-through alone, regardless of how good the pass-through is not acceptable from the perspective of the FDA. So I think inevitably we're going to have some kind of transparent display solution along with high fidelity imaging, which is, I think, the great technical hardware optics challenge right now that's facing the field.
Thank you. Where do you see records in your daily business? I mean, the RecordXR functionality.
Oh, yeah. So RecordXR is a fantastic function. I think RecordXR to me is like, you know, MP3 was for music, MP4 was for video, MP5 is RecordXR. I think the entire future of education, the compendium, recording, virtual reality, being able to record surgeries that we performed, to record the plans that we performed is all going to be done in the MP5 or RecordXR file format. I think that there'll be a kind of a schism where the Apple Vision Pro will be very focused on this kind of RecordXR equivalent for them in entertainment. And I think RecordXR could become the DICOM equivalent or like the medical standard inside the medical field for what we're passing around as files to each other.
Another question from Sarah, if I read the question right, it's where do you see, when can virtual reality surgical planning be reimbursed by insurances?
Yeah, so that's a great question. So we're working on that right now. You know, I've spoken to a few companies now, one called Macra and a few other companies to try and figure this out. But I think the future is going to be a CPT code and reimbursement in the United States, at least, for virtual reality planning that's being submitted to an electronic health record, which I think is going to be lagging. That's going to be the last piece because the Epics, the Cerners, the electronic health records of the world are the least technologically advanced companies there are. And I have a vehement lack of trust as far as their developing process is concerned. When it comes to the other options, though, there are CPT codes for an enhanced informed consent. So you could have a patient come and see their scan in clinic, and you could get paid an additional CPT and reimbursed properly for actually taking the time out to show their information in virtual reality and increase their objective comprehension for surgery. I think there's a lot of benefits to that. I think the other component is you'll have a new CPT code for implementation of VR planning, just like we have planning in radiation oncology before we do radiotherapy or radiosurgery. And that doesn't have to be submitted to the EHR. That'll be something that as long as you can show some kind of evidence or proof or a statement that says that you did it, you could be reimbursed for it as part of the surgery, right? And then finally, I think there'll be a reimbursement or a CPT code for the use of augmented reality or some type of mixed or spatial computing platform intraoperatively. And I think that'll be paid very similarly to the way we're being paid for navigation right now.
Thank you so much. We have a question from...
Thank you for your talk. One question, your role for radiology was quite technical in image acquisition. The question is, where do you think radiology could help you and support you in operation planning using virtual reality?
Oh, so my brother's a neuroradiologist at NYU. We talk about this all the time. You know, I really believe it comes down to understand. How do I put this? In the research world, there are great protocols and papers written around 1.5, 3, and 7 Tesla MRIs for neurography. And where we struggle right now is being able to trace nerves and to trace their path through access corridors to the spine. So for example, the psoas major, the muscle that travels down the lateral aspect of the spine, I would love to have a sub 1 millimeter protocol for thin cut prone neurography MRI. So what'll happen is I could have an extremely thin cut MRI in voxel space, and be able to merge that to the CTA, have both the vessels and the bone being prominently displayed due to a preset based on Hounsfield unit, merged by landmarks to an MRI that's a thin cut MRI designed around neurography, and be able to superimpose that on the patient when I do a lateral approach to the spine. That way I can avoid the vessels, I can avoid the nerves. I know exactly which tendinous fibers of the muscles exist. I know exactly where the fat plane is before I hit the spine. And each imaging protocol should be able to complement the other one. So there'll be a whole future. I hope radiologists would pioneer this, but it doesn't seem to be the case right now. It looks like the surgeons are kind of the vanguard, unfortunately. But I would love to have the radiologists on board and do thin cut CTs, thin cut CTAs, thin cut MRIs, and make it an entire discipline where they're publishing around stereoscopic fidelity for examining patients. I mean, it's to their benefit. I think in the future, radiologists would prefer to see holography, essentially, of their imaging and get closer to their patient care, basically.
Okay, thank you, Galal. I think we have one more question from Silvan.
Just one more question in general. Thanks for the great talk. Where would you see the biggest hurdles for intraoperative use case when it comes to VR or AR technology, besides the, let's say, regulatory aspects, which you already mentioned?
Yeah, I think the biggest hurdle is in the hardware, right? So the biggest hurdle is understanding the needs of the surgeon, which is beginning to become more clear. And what I mean by that is, like Mark said, Mark's very clear. I don't want to wear a headset, right? But we wear glasses, we wear glasses no matter what. You have to protect your eyes from the splashing of blood. So the great challenge is in the optics, in the world of optics, is being able to build a transparent display that allows for non-obstructive vision, but still allows for high fidelity superimposition and allows for transparency and opacity at will, and also allows a sense of depth or stereopsis to it. It's a difficult hardware challenge. But I think the concept of building it into loops up front is a pretty good solution at this time. I think the next big limiter at that point is going to be battery technology, is being able to have it wireless or not tethered and still function in high fidelity. And I think it's a matter of time. I don't think it's something that's not coming. I think it's just a matter of time, and probably in single-digit years. So it's better to plan for it now than wait.
Thank you so much, Galal. Thank you for your insight. It was very, very interesting to see where you think the technology goes.
Galal, good. Sorry, I know. I wanted to ask one more thing. I keep popping up, but like the big thing with us is, like, honestly, like I do the odd like baby surgery and things like that, and I have my 3.5 loops and everything, but the big challenge is a lot of our cases are minimally invasive, so they're thoracoscopic and they're laparoscopic, and we're using 3 millimeter cameras, and so the big challenge for us is going to be, and that's why spine and dental and neuro have been sort of the first targets for a lot of this stuff, is because they tend to be sort of stationary objects, whereas what we're looking at is, like, so if I want to look at a liver and do an overlay, like the positioning of the liver changes with each breath, and if I elevate something, the whole thing goes askew. And so I think, and I don't know if because you mentioned you guys had an endoscopy group, I don't know if anything similar in terms of overlay exists for your version of endoscopic surgery, but in terms of, the future, a lot of the future of that is going to be sort of AI enhanced sort of registration of all this stuff we make onto the actual organs, so that the overlay and the signposts and all those things are present while you're doing the operation.
Yeah, so right now we do endoscopic spine surgery. It's a lot of it is we also do endoscopic approaches to the skull base and to in the brain. Yeah, we've benefited from having a relatively stationary organ system. That's why I've been able to have navigation and sub-millimeter precision when we do our surgeries. The difficulty, the way we've surmounted some of that is with Florida CT merger and merging things with intraoperative scans that are X-ray based. Obviously, these are radio opaque objects. It's not like what you're operating on, right? So as far as what I see the future is it's going to be a machine vision component. So what we have right now is a navigation platform called 7D, which is based on multiple cameras that are kind of like an OR light above the surgery. And they'll take a 3D image of the spine and then merge that with the preoperative CT and do it all very quickly. It's called the 7D flash. I think that that's like the caveman paintings on the wall. That's the primitive future of what machine vision is going to offer in surgery. So for example, we'll eventually have stereoscopic endoscopes, okay? And you'll be seeing a three-dimensional view, and using a stereoscopic endoscope, I think the registration will be able to learn over time while you're inside the patient what the movement is like, be able to find the appropriate landmarks, find its own fiducials, its own like specific fiducials, be able to tell you the fiducials are there. You don't interact with those fiducial intraoperatively, and it'll be able to track those organs for you in real time. I think that's coming as well. It's just a matter of getting companies invested and thoughtfully caring about the development of the technologies we need in surgery to perform safe surgeries. Because right now, you know, the only reason they ever listen to us, and I'm sure you know this, Mark, is with alignment and reimbursement codes, right? So if we have alignment and we have reimbursement codes, the companies are all on board, right? So understanding the regulatory component, understanding the reimbursement components of it, then they feel like there's a large total addressable market at that point, and then they want to actually invest in producing these types of products that we need. The technology's there. Like, that's what I'm trying to say, is like now with OpenAI and what we've seen, the tech is there. It's just a matter of integrating these things across platforms. And if we don't demand it, they're not going to build it. That's what I've discovered in my short period here, you know.
No, I mean, I think I keep assuming anytime I come up with something that like somebody must have done it already, but it's just the best I got so far is like I can pay Ethicon $500 per patient to segment somebody for me, and that's it. I mean, there's a couple of companies doing something similar, but that's you're going to give them a 2 to 3 day turnaround, and you get back some segments, and you can clip vessels and take out lobes and things, but like I can do that stuff. So like that's what I need, is in terms of how to take it into the OR and how to implement, so in my mind, because like MD Anderson, for example, is world famous, cancer place, whatever, and they print all their stuff. And so like and so in my head, that's like a lot of time and money and stuff, and just to see, and if I want to see, I can put the goggles on, I can see, or I can do my quick and dirty like 3D slicer thing, I can see it fine. But like but in terms of in terms of for you guys, like for planning trajectory, or for like practicing, because you guys, the difference between our specialties, I guess, is that, or what I've come to appreciate, is that you require like very precise sort of angulation and trajectory and like depth and like things like that I don't, because I have a moving target. And so like the mechanics of it require a lot more precision. And so I think any way that you can sort of improve that, and any way I can achieve that with with any of these scans is very helpful. So but I learned a lot from your talk. And you gave me, now that I got this expensive toy I bought, now I'm gonna go try and plug it into the laparoscopy camera and just kind of see what happens, and just to see if maybe that's a thing. But no, again, I appreciate it. It's not very often I get to talk to people who, especially surgeons, who know anything about this stuff. so
It's rare. Hey, I need to connect you, Mark, with a friend of mine who does he's able to use the endoscope to create stereoscopic and 3D layouts of the anatomy, even from YouTube videos, for example, using Polycam and using LiDAR sensors. So if you're able to hook up your 3D glassless monitor to like a laparoscopic setup, you could probably build like a 3D model as you're traveling through. You see what I'm saying? Just using machine vision without If you
Yeah, this
had
one-
LiDAR, you could do it even more effectively, and then that reconstruction could be superimposed for you, like merged with whatever plan you had in Medicalholodeck, for example. Like that's the future that's coming. It's just like we're just sitting here waiting,
and actually the software that comes with, as of right now, I can look at it's very, very basic, but what it does do is I can take for example, like I can take the Zoom meeting if I want, and I can run it through and it'll ask, is this a stereoscopic, a side by side, or is it a 2D display? And it'll run it through. And I have a 47 or I have a 4080 on this thing, and I can run it through, and it will do its best to sort of approximate, using depth cues and things to sort of figure out what goes where. And so it's a very convincing sort of 3D image, at least for Zoom, especially like if you got a blurred background or something, like you're gonna pop to the front. But like I don't know what I would do with that, but but I can do it. And so I wanna try it on stuff now. And you gave me an idea. I'm gonna try it on my cameras and see what happens.
Sounds great. I'm very honored and humbled to talk to you all, by the way. Thank you so much for this opportunity. I really, really appreciate it. So it's good to see other surgeons struggling like I am. So it's nice. So thank you, guys.
The fact that I saw a video of you using Slicer in VR, which tells me the level of jankiness you're willing to sort of put up with. And so, I think that tells me all I need to know about you. But that was awesome.
I am also into the jankiness, and I am also intimidated by GitHub repositories. So I'm with you, my friend. Don't worry.
Great. Thank you, Galal. Thank you so much for the insight, also the questions. Thank you so much also to the audience. If you have questions, just use the chat form. Just write it into the Q&A chat form, and then we will forward it to the speakers. Thank you, Galal. Have a great day. And we switch seamlessly to Dr. Jan Arnsmeier from University Hospital in Bonn. Hi, Jan.
Yes, hi, good day. I hope you can all hear me. I will also try to share my screen away. Just give me a quick confirmation if that works.
Yes.
Yes, excellent. Okay. Yeah, thank you so much, Chris and Dominic, Thomas and team for inviting us, for having us. My name is Jan Arnsmeier. I'm a thoracic surgeon by training. I'm also the managing director of a newly founded Bonn Surgical Technology Center, the BOSTA, here in Bonn. With me, not really with me, but in Zurich and present is Philip Fiodorovici, our technical director. I was also planning to be there, but unfortunately a flu got me hostage the week, so my whole schedule got messed up. So I'm now doing it remotely, and I hope this will still be appropriate for you to follow everything. As mentioned before, thoracic surgery is our profession, it's our field. And I want to give you a little bit of a glimpse in our latest developments of our field, how image guided surgery, image guided preparation of surgical procedures are taking their role in our field, and also give you an idea on how we approach to solve the infrastructural issues that we're all facing. We saw some previous comments also here in the chat in terms of how cost intensive, how infrastructure intensive the rollout of broad XR technologies can be made possible. Quick disclosure upfront of potential conflict of interest that might be in relevance to today's talk. The transformation in surgery, I think we already heard a lot from the previous speakers. We have these three baseline technologies, AI as being, the big thing everyone's talking about, data-driven decision-making, decision support. We have to get decisions visualized in some sort of extended realities. We are talking a lot about head-mounted displays today. We've already seen a lot on holographic displays, on semi-transparent goggles. Maybe even laser-driven holograms can be something we will see in the near future. And in our field, that's the main domain now for the actual performance. We are carrying out therapies using robotic assistant devices. Maybe on the technological endpoint, this will all come together in semi-autonomous or autonomous procedures. And this all impacts the future of training. And this is also the reason why we founded this center here in Bonn. I'll give you a quick idea. It's quite new. We are in this building for a couple of months now. The Bonn Surgical Technology Center. We're doing research and education there, and also hosting events. few visuals. Robotic surgery is a big issue. I will come to that in a few seconds. A little bit of history. How did the OR in our field develop? As in the most domains, in the 50s, it all looked a little different. You can see hygiene was a little different. There was not really sterile environments back then. That came around the 70s, 80s. You see there's a lot of difference in how patients get covered, how the nursing, the staff is also covering themselves. The sterile environments got implemented. And this is how most of the ORs in the first world look today. We have imaging, we have monitors, we have a technological methodologies in the OR already. There's minimally invasive techniques. We have the chopstick instruments. We have modern lighting. So this is how it looks in most of the ORs today. This might be a picture of the future. You see there's imaging integrated, there is robotics arms integrated. This is not it's something I took from the internet. It's not just probably not the thing we will see directly, but I think there are a lot of components that are already being brought into the OR. So minimally invasive surgery is the thing from the past 20 years, is still standard of procedure in a lot of cavity procedures in laparoscopic abdominal surgery, as well as in our domain in thoracic surgery, the VATS, the minimally invasive approaches in thoracic surgery. So we have these small incisions, we use our chopstick instruments, we use the cameras, we use stereoscopic cameras, we have 3D vision usually already into place. And to comment on the discussion before between Mark also and Galal, yes, we are also really eager to see image-guided overlay from our previous and preoperative CT scans in this OR. We know that there are, in the scientific world, there are some approaches already. There are some open challenges, some open data sets on how to deal with the deformation of the liver when it gets turned, how to still be able to have an accurate overlay on where is the tumor, where are the vessels, where are the critical structures. So yeah, the science is taking some steps there, and I agree to Galal, there has to be really some amplification in terms of industrial money probably to really bring out a product. It's still kind of the holy grail, but I think, and also what Galal said, stereoscopic vision does provide us already the correct data to create those 3D environments and then AI driven create those overlays. I think the technology is there. I agree very much to what Galal says. We can see almost not really in real time, but we can see 3D mapping already from stereoscopic imaging, also AI driven technologies there. So I think we are quite close. We are not there yet, but the technology is already there. So robotics, as mentioned before, is what we're facing today. I think in the US, the past year has already been the threshold year where there were more robotic procedures carried out than any other entities, neither open or conventional endoscopic surgery. So same goes for Europe. We are a bit behind in that domain, but we are facing an area of probably almost only robotic surgery now, also in our field in thoracic surgery. So the main difference is we have the EndoWrist technology. You can see this here on the right side. The instruments have way more freedoms in terms of movement. They call it the EndoWrist technology, though the internal wrist to really be precise in the preparation. The main manufacturer even calls themselves like this. It's very intuitive when you use these joysticks to actually have scaled transition of our movements in the situs. Really elegant, really precise, and it's really a change of the whole setup as seen here before. The surgeon is kind of disconnected to the patient. It also has some disadvantages, but it's a complete different setup in terms of how we actually are performing, and also in terms of well-being of the surgeon, of ergonomics. It's really a changer. Current developments are trying to be even less invasive. Uniportal robotics are coming on the market now, single port devices. So only one incision. The instruments, like little worms, they spread out to have the right angles of attack again and still be able to be moved by the joysticks. I think one major comment here is also to make clear that in surgical robotics, there's not really, in our domain, there are not really autonomous systems yet. So it's all fly-by-wire. It's just telemanipulation on a short distance. Yeah, just to be clear here, how we stand with robotics. This is how it looks like, actually. How those robotic procedures are carried out. This is typical lung procedures. I'll just quickly skip that skip to the videos so you get some impressions using endoscopic staplers, robotic staplers to dissect vessels. You see this really fine preparation with really angled instruments here to attack these very delicate structures. You really don't want to harm this vessel here. You can see it's pulsating. It's already dissected here. If you harm this is really a major bleeding. If you've seen this once in the OR, if it happened to you once in the OR, this is really a kind of code red. We really don't want to see this, and especially in pulmonary surgery. We have to be very careful here. But you can see it's really elegant to prepare with those devices. Really efficient. It's kind of the new standard of care, especially in sublobal, in segmentectomies, sublobal lung resection, our main domain, lung cancer surgery. This is really the way to go now. Quick glimpse in AI, in AI-assisted or computer-assisted surgery, just to bring you a little bit into this topic: intraoperative decision support, decision assistance. You see on the right side, that's just analogous comparison to autonomous driving. So we have the RGB camera pictures as being our sensors, and AI allows us to classify actually the environments, to classify what we see around. Same goes for the surgeon. So this is just a little short model that we train just to track this one specific instrument. So we're doing that as well. We're training models to detect critical anatomy, to detect our instruments, to detect critical phases. So this is what's also coming in the future in the intraoperative domain. All right, now switching to the preoperative and the perioperative phase of our patient passes and actually our work. And now we bring in what we are doing with RecordXR technology. This is maybe something we are not too far away from. The future consultant's office maybe looks like this. This is just, Hollywood from Iron Man, an immersive environment, an engineer, having a voice-steered assistant and AI he can talk to, and he gets visualized a lot of, mechanics and mechanical anatomy around it, and he can just interact with it, compile things together, estimate how many things would work. And I think this is what we are doing right now. This is the area we are maybe at the start right now, and these are the use cases that we are trying to work on. Mainly the ones on the left are the ones we already have been quite experienced here now in Bonn, and the ones on the right, patient information, case confluencing, we want to try to implement that also in the near future. And yeah, I will try to give you a little examples on how we approach those and what our experiences have shown. So in virtual reality, as seen on the front side here, we try to do surgical planning, especially in complex oncological cases. So this example here is showing a chest wall invading tumor, lung carcinoma. Quite difficult to make a good decision here on how to approach this. We were trying to find out whether this could be suitable for a minimally invasive uniportal approach. So we were using the software, real-time volume rendered software of Medicalholodeck, to estimate whether our instruments could reach it, whether we had to remove a lot of the chest wall, remove the ribs, etc. So this was quite helpful. We did it also in a multi-user approach through our main hospital and our other facility that we are working together with. And we have the mixed reality environment where we're exploring the potential in overlay navigation, especially also in complex cases, chest wall surgery, as shown here. If you see the slicing tool now, you can also maybe get an idea. This is quite a large tumor of the right cavity, also invading mediastinal structures, diaphragma, chest wall. Really difficult to plan this, whether we do the approach, sternectomy, anterior approach, anterolateral thoracotomy. Do we have to have an extended incision here? So a lot of questions are being raised here up front, and I think we can already say that those three-dimensional vision, especially in overlay, really would help us in an accurate preparation. Yeah, why is volume rendering important for us? I think that has also been mentioned before. I think Mark already said it. We have all the information. We have the information of the whole CT scan. It's not just a segmentation of something that the radiologist provides us. It's not something that an AI provides us that is additionally helpful, but in the first place, we as thoracic surgeons, we often need to have all the information. We have to have the soft tissue, the skin surface, the lung parenchyma. Everything has to be displayed or be displayable and be visualized for us. So we really feel that volume rendering and dynamic editing, as provided with this, tissue windowing tool, also in Medicalholodeck, is what we need for surgical preparation. This is where we started off with in 2019, 2020, when we started with education of our graduate students. So we wanted to make sure that we have performative volume rendering, but still be a little bit mobile on the campus. So we took this workstation. I think there were 2080s Ti back then in those server rack, so we can move that around the campus, having those wired Oculus HMDs connected. So every student could do this volume rendering. We were also using Team back then to meet up together in the same XR space. No spatial anchoring, but it worked quite well. And we actually did a curriculum for case-based teaching. I think Galal also said it. It's for us, it was more like a conventional case-based approach, presenting a case, presenting the surgical approach, the surgical idea, explaining the anatomy, explaining the minimally invasive approach, everything that would have been quite similar actually in the OR, and the students really liked it. They really enjoyed it, and they I will also come back to that. They really gave us great feedback that really enhanced their understanding of thoracic surgery. So from an infrastructural perspective, and this is also what we are carrying out in a big project, a governmental funded project at our campus now, is to go from this to a broad campus-wide solution where we have wireless access to high performance XR and volume rendering included. So what we did is we created a central server with A40s, NVIDIA A40s cards as hosting those instances. And then they start up the machine, and having a virtual machine running on just displayed on the actual XR devices, and provided and distributed through a strong Wi-Fi network, and even accessible through 5G as an addition. So this is the idea, and it's already running as an MVP on the campus now. So this vision of every consultant, every doctor can have now, very simple Meta Quest, whatever goggles in their office, and they can, put it on their heads, and the instant will start in the central compute station at our campus. And the device, they just receiving the stream, and we have direct patient data access. We have high performance rendering capabilities available for everyone, and it's also efficient. We can connect 100, 200 users on this one server if they're not use it all at once. We have quite an efficient distribution of compute power here. So this is what we're doing right now as a campus-wide solution for high-performance XR now in Bonn. Coming back to the education, so we asked our students how they liked it. We did a quick evaluation and assessment on how this case-based teaching was for them. And just to point out two of the results, I mean, they were astonishing. They were really overwhelming, that they were really enjoying it, that they really saw so many benefits of it. But of course, anatomical relationships, understanding anatomy and the surgical approach, and XR teaching was fun. I mean, they really enjoyed it, and this really is a good marketing. Really brightens also our field of surgery in times of shortage also on workers, not only nursing but also upcoming surgeons. Quick comment on cyber sickness, on motion dizziness. I think 5% is quite a good number. I think we only had one student who really had to stop the session of those also 70 that were participating. In the clinical use case, so this is the challenge we are facing. We have the 2D grayscale imaging. I think that's as mentioned before, and especially in thoracic surgery, there are nodules somewhere here in the lung, sometimes peripheral, sometimes very central. Very, very hard to determine where they actually are. It's a little bit like liver surgery, but even more complicated, with this big and very, very soft and deformative parenchyma of the lung. And then we are challenging to find this nodule or this tumor or whatever pathology actually in the OR. We were trying to evaluate the real impact, the real benefits of using XR, and this is also maybe quite similar to what Mark already has shown. Congenital malformation. We are operating those newborns quite often at our center, and they are challenging. Those CT scans, they don't have many slices. They have quite a bad resolution. It's a very small body of a newborn in this big CT scanner, so they're especially challenging in terms of surgical preparation. So what we did is a 2-arm study in our center, experienced consultants, experienced surgeons, and residents as being the two groups, retrospectively evaluating cases of congenital pulmonary malformations. And we asked them to do a retrospective assessment as a simulated surgical planning, but of course then knowing what was actually going on. So, and I want to, so there was a total of 222 assessments in 2 groups, so 112 in each group. And we were comparing XR to conventional 2D grayscaled surgical preparation. And just, it's not published yet. It's very brand new results, but a few results I can already present to you. So the predictive value was actually higher in the VR group for diagnosis, and the diagnosis being the ground truth, the actual histopathological finding that we got from the cases. So quite interesting, and the strongest subgroup of all, so no matter 2D grayscaled, XR experienced or residents. So the residents in XR was the strongest subgroup in terms of determining or predicting the correct diagnosis. Quite interesting. We're still discussing a lot why that is. There were not so many difference in terms of location and the actual procedure. There was a lot of difference to the actual findings in general, and XR assessment took longer. That's for sure. There were about 3 to 4 minutes in XR and 2 to 3 minutes in 2D. Might be that just the method is new. People had to get to know the new tools, the methods themselves, get to use to the spatial computing space in general. Not all of them even had an XR device on their head before. Some central consideration for our field. I think we already demonstrated that there is real impact, that we see that there are studies being published every month. We are now in the phase that we are now proving that XR technology really helps us. in preparation, in overlay preparation, in mixed reality environments. The implementation, very, very important statement, I think, is highly dependent on usability. At least here in Germany, the surgeons, the workload aside, technology really has to function. It really has to, unveil the potential within seconds. Doctors really have to understand and grab very quickly that it works, that they can use it easily. So usability is really a main issue. I think AI will also be a shortcut here. If we have voice commands, if we have easy segmentation, that's really something that really amplifies this year. And I think we demonstrated that high performance XR can be made possible also for everyone on the campus using a cloud-based solution. So speaking of AI, to give a glimpse in how we use this already. So especially in thoracic surgery, I think this is another game changer. So having pre-segmented anatomy here is really important, and that mainly goes for lung surgery. As I said before, lung cancer surgery is our main domain, and we will also in the future, we will have more and more, small tumors, small nodules to clear. And the oncological approach usually for smaller tumors will be the segmentectomy. So not removing a whole lobe as has been pre-segmented here, but just a segment of the lung. And the anatomy in lung segments is really, really variable on each case. So patient individual planning really does have a role, and I think there will be some reimbursement in the future when it comes to surgical preparation in complex lung surgery and in subglobal lung surgery. So AI, as being a shortcut in visualizing the really relevant structures that we need for our preparation, that's really really a game changer. Another model here, there's another commercial offering here, and that already trained a model, for lung segments, determine where the boundaries within the parenchyma lie, where the actual vessels, bronchs, the whole vascular system in accordance to the segments, really helping us to plan those segmentectomies. Really something that we want to also bring to XR in the future, really something that we would need. And to give you an idea how we solve this issue on determine the lung segments now, with a fluorescence guided approach here with ICG. So this is the tracer that gets injected into the patient just prior or during the procedure, and we see it circulating in the body. And after we already dissected the blood flow to the lung segment, we can now see the boundary of the parenchyma. It's an invasive method. It's elegant. It's really helping us. But as seen before, we already have this information. So and that's a technology has to solve us now to really bring the information that we have before into our interoperative setting. Solving the issue of deformation, solving the issue of correct registration. That's what we need in the future. I think that will be solved very soon. So this is the team or some of the team members here from Bonn, to give you an idea on how we all look like. And also a big shout out to them. Thank you so much for your attention, and I'm happy to answer your questions.
Anybody has some? Thank you, Jan, first of all, for the interesting talk. Does anybody here has some questions to the audience? If that's not the case, Jan, maybe just quick, you also do a lot of education, also international collaboration with VR. Can you give us a very short insight of how this looks like?
Yes, you mean the international collaboration project?
Yes.
Yes. Yeah, we have a few ones going on. I will give you would like to mention one because it's quite an interesting one. So We have a partner clinic in Uganda. That's a Lamu hospital. One of our colleagues here from our department, he's a plastic and reconstructive surgeon. He built up this center, and we are now trying to evaluate whether XR technology can actually be a solution to democratize surgical knowledge, especially in low-income countries. So the cases down there are quite complicated. There's a lot of acid burns. There are war wounds, quite drastic, quite dramatic cases also down there. Large tumor masses that are not being seen by anyone. And there's a small surgical team. They're well educated in terms of what they're able to do, and we're trying to bring sophisticated knowledge from complex reconstruction, that the knowledge is somewhere on this planet. And so what we did is we did actually photogrammetric scans of those cases in Uganda and brought them into the XR platform to discuss those cases and bring this knowledge. Very interesting project, will be published very soon. I think this is it's not only a noble use case, but it's really mind-blowing to see that the plastic surgeons who did this international global case conference on those cases also really enjoyed it and had great feedback. I think there were more questions on the chat, I think.
We have quite a long question from Gabriel. I just read it through, okay? So VR and AR technologies are extremely accessible and make the use of DICOM imaging studios accessible to everyone in our hospital. We noticed some knowledge gaps in the field of image interpretation among doctors who are not imaging specialists. Is this situation repeated according to your experience in your hospital? What strategies could be used to mitigate this problem?
Yeah, so to speak from our experience, in this study I presented where we were analyzing those newborns, congenital pulmonary malfunctions, the surgical team, the residents, as well as the experienced surgeons, the consultants, they were almost 100% correct to the radiologist in terms of the questions we ask, diagnosis, location, extent of the. So there wasn't that much difference to the actual radiological findings. But I agree that especially new to the field, maybe not being so much in the surgical domain, that can be an issue. We talk a lot about with the pediatrists, with the neonatologists. They are not used to interpret imaging so often, so we see they really have a lag, and they really said that they would need this technology because it helps them so much to much easier interpret those images. So it's a matter of how you are used to work with imaging, with preoperative imaging. We as thoracic surgeons, almost every case has a CT scan, but there are other entities not being that used to it. So we think the approach that we are doing, trying to provide to every clinician this opportunity to 3D visualize their patient data, is a step to go.
Thank you. I just go through the next question from Matthias. How do you see the registration image patient happening? Through AI-based visual recognition, maybe in combination with a position tracker on the laparoscopic lens? Do you have any experience with this yet?
Yes, I think there are several approaches, and I think some sort of AI will be in the back end of those solutions. So what we did is we did a registration. It's an experimental. We haven't published it yet. It's just a few weeks ago. We used an external tracker, very precise tracker, and point cloud model to overlay the CT images and to accurately align it with a reality. So this has been proof of concept. It really does work. But what we all want is we want to also have it in our minimally invasive environments. So I think there are a few, as I said before, there are a few challenges. So I think it will be at some point possible to only have our stereoscopic camera as an input the data as an input and have the CT to be overlaid in there, or whatever image data we want. And we will be able to register the position just by the image data. There are a lot of technologies, neural radiance fields, Gaussian splatting, stuff like that. A lot of technologies, AI-driven technologies to rapidly detect a three-dimensional environment from stereoscopic camera vision. So those technologies may play a role here, but I think it will be possible only by the stereoscopic camera data to bring imaging in there and align it with the anatomy.
Thank you, Jan. So one last question from Elisabeth. I would like to know if there is much difference in use between headsets with and without hand controls.
If there's difference in the usability.
Yeah, it's use hand controls or hand tracking. What is your experience on that?
Yes, hand tracking is great, especially in setups where you want to have your hands free, and if that works reliable, it's a better choice than having hand controls. For now, the controllers are they're more reliable for now. We have very precise tools there. But I think it's a matter of time where we have other user interfaces like voice commands, and we will have eye tracking. Apple Vision Pro, we just tried it out. Amazing UI for this eye tracking, and just a fingertip to confirm the control. This will advance rapidly within the next maybe months even.
Good. Thank you so much for the insights, Jan.
I think there was one more question about the publishing. Yes, the student evaluation data will be published very soon.
Okay, good. We are looking forward to that. Then our best regards to the team, and thank you for your presentation.
Thank you so much.
Now we welcome on the stage the section master, Evan Goldman. The presentation.
Get started. Please quickly.
So just we are very happy to have Dr. Evan Goldman here speaking to us live from Zurich. So he is the man behind the dissection master. He created these awesome dissection data, which we published together now in the last, I think, 3 years. And very happy that he is here today and giving us an insight on how difficult and how much work it is to create this kind of anatomy data. Thank you, Evan.
Right. Thank you very much. All right. Good afternoon, or good morning, or good evening, because you are all over the place in the world. Yeah, my name is Evan Goldman. I am the director of anatomy at Penn State College of Medicine, which is in Hershey, Pennsylvania. For any of you who've heard of Hershey chocolate, the factories are right there. So if the wind is blowing in the correct direction, you get to smell chocolate, and it actually smells like chocolate chip cookies everywhere. Hershey, Pennsylvania is also amongst cornfields and other agriculture. So if the wind is blowing the wrong direction, you do smell manure. So make sure if you visit, you come on the correct day. All right. So what I'm going to talk about today is the process of creating these virtual dissections, or the dissections that wind up creating the content that you see on the medical holodeck. Are we okay here?
Okay, thank you. Sorry.
Okay, no problem. All right. Disclosure, I am part of the medical holodeck team. Magical. All right, let me give you a little bit of a background, a brief history of what I did to get me to where I am now. About 10 years ago, I had a friend who was a YouTuber. He did product reviews, and I was over his house one evening. And he showed me this tech, which you've all heard of, called the Microsoft HoloLens. I was very excited to see it. I'd heard of it. He showed me the educational software that was being used at Case Western Reserve University in Cleveland, Ohio, to teach their medical students anatomy. I was duly impressed. Very, very neat technology. You could rotate anatomy around, and I couldn't help but think, could I use this technology rather than using computer graphics, convert this into something which was actual cadaveric anatomy? So I got a small grant, got some equipment in, and I began creating models. And the one you're looking at right now was one of my very first models. And you can see there's lots of error in it, lots of artifact in it. But at the same time, I felt it came out pretty well. You can tell that it's the back of a person. So years later, I came up with, or continuously improved my protocol. So that's what I want to walk us through a little bit right now. The process begins with dissection. From there, there's a preparation that occurs. That's more work than you can imagine, but I'm going to talk through that a little bit more in a moment. And that's the preparation for the filming process. And after the filming happens, I have a data set from which I'm able to get a model, a 3D model. And then there's a lot of post-processing that occurs as well. So I'm going to walk us through some of that process that I go through. All right, so here, if you're used to using, or if you've used Medicalholodeck before, then you've probably seen this hand images before. So obviously when I receive a cadaver, it is unembalmed. Then we embalm it, and then it has the skin on, and then we have to undergo, the dissection process. So the image all the way on the left side of the screen that's like a first layer of a dissection that I would do, meaning that I would simply take a scalpel right up the anterior forearm and expose the structures. And I'm not sure, of course, how well you'll be able to see any of these on your home computers. But over here, we have some fat or adipose, and right underneath that we have some veins that are running through there. And over here we have little nerves that are running through the skin. Here we have some tendons, and those tendons are covered by a membrane. So that process, that's an easy dissection. So that's maybe a couple of hours of work, not even that many, possibly. So that model or that dissection will then be set up appropriately. And when I say set up for this one, it's very, very simple. I would simply be taking some sort of a structure to bring the skin out to the side, and then I would film it, and then I would process it and post-process it. And for something like this, which is a simple model, that is a total of maybe 30 hours of work, which is a week or more of work. Some of the more complex models are about 100 hours of work. So that's weeks of work between each model. So jumping to the next dissection over here, this is a couple of layers down, each of which would maybe, be a couple of weeks and maybe 10 hours of dissection work. And I want to point out that all of these dissections, I make choices with everything. It's not just, hey, I'm going to dissect this. For those of you who are physicians, anatomists, anatomy is dissection is a very destructive process. And I can't have it being destructive. I have to isolate every little structure. So I made choices on this one that I wanted to see some of the nerves and the arteries that are going to the hand. There would have been veins on here, and I usually keep the veins at least in one layer, and then remove them or reflect them in another layer. This one was just about those structures, those arteries and nerves going out to the fingers. Up here, you can see there's a radial artery, and over here, there's an ulnar artery, and they're coming down and going into the hand. You can also see over here some of the muscles of the hand that are controlling the thumb, and on the other side, those are the muscles of the hand that are controlling the little finger. So again, same process at this point. I take this model and then go through the process of setting it up, which I'll show you in a second, and then filming, and et cetera, getting down to finally a model. This last image over here, this is about 2 further dissections down, and all of these structures, these previous structures, have been removed. So now what you're looking at is a carpal tunnel. This is obviously just a flat view, so you really can't see the 3-dimensionality of this carpal tunnel, but this is the median nerve running through that tunnel, and the ulnar nerve off to the side. With a number of the fascial layers removed on the hand, you can see some of these deep tendons, and you can also see some of the intrinsic muscles of the hand. And one thing I wanted to point out, if you take a look off to the side here at those muscles that had been previously overlaid to see the muscles that control the thumb. I've cut some of those muscles purposefully, but I'm still showing the deeper muscles. Similarly, I've done that on the pinky side or the little finger side, where I've cut some muscles to show some of the deeper muscles. All right, that's the dissection process. The next process is this filming. I'm sorry, the preparation for filming process. It looks in the picture like the same thing as dissection. This is definitely far different. The purpose of dissection is to find different structures and to isolate those structures and then to clean them up. So I'll remove little bits of adipose or fat tissue and little bits of tissue. This is a different process. This is in preparation for filming. So I'm sort of setting the stage at this point. I'm setting an environment where I can film it. Everything's held in a position. And let me walk us through that process a little bit more so you can understand some of the challenges here. So I have a goal in creating each model. And the goal is not what a student might think, which is, hey, what is the name of such and such a structure? I just want to learn what the name is. In creating these, the goal is to teach three-dimensional anatomy, the three-dimensional relationships of every structure. So in order to do that, I have to make choices. Okay, so this might be a sternocleidomastoid muscle right over there. The challenges. Okay, so the first choice I'm going to be making is I need to figure out how to reveal deeper layers without moving a structure out of the way, or without removing structures. So as I just showed you in this video here, this is essentially the process, or one process I would use to be able to do that. So what you're looking at there is not just the sternocleidomastoid, but there's a little nerve, actually it's a large nerve overriding that muscle, which is the great auricular nerve. And what I really wanted to show in this model was where that nerve comes from. So I'm pulling this muscle over just with some sutures, and now you can see right there, you can see where it's coming from, which is some nerves deep in the neck from the cervical plexus. So that was the goal here. So that's how I overcome these challenges. Rather than cutting things, I try to I try to move things out of the way. Just imagine if I wanted to show that cervical plexus leading up to the auricular nerve, and all I saw was just that nerve. That doesn't show you anything. So between each dissection, I really need to make sure I don't remove important structures. Now, the second challenge, though, is I need to maintain a correct or a concept of the correct position. So what I mean by that is if I've taken all these structures and I moved them off to the side and I'm a student, I want to understand where the structures should be. So in this case, this is a transverse colon. So we're looking at an abdomen here. This is a transverse colon, which should be lying somewhere underneath the rib area. And this colon could be here, or it could be maybe 10 centimeters lower than the rib cage, or 20, maybe even 30 centimeters below that. Everyone's a little bit different. In this case, I don't want the students who are learning this to get a misconception that this colon is way up high over here. So I'm telling them by having this retractor in there that this is out of position. So when you're looking at the models, you will see sometimes that there are instruments, the retractors. I've left those in there on purpose. I've laid them out in very specific orientations to give you the concept of what the correct position is of something. The next challenge I have is the cameras. In order to see something in the model, the cameras have to be able to see it. That sounds pretty obvious, but when I'm filming, it's far from easy to do that. So in this picture over here, what you see is I've got some sutures off to the side here. It's hard to tell perhaps on your screen, but these sutures are holding onto some vessels. There's a suture here, a little suture there. This you can't see perhaps. It's a 3/0 suture, so it's fairly small. And I'm holding onto this arterial tree, which is part of the inferior mesenteric artery system. So if I didn't have those sutures there, those arteries would be essentially flat inside the abdomen, stuck against some of the structures that are there, but I want to see those in the model, so I have to hold these out in this abnormal position. And that is what I'm doing throughout the entire body. I have sutures, I have wires like this that you see here. The purpose of these wires was I was elevating the rib cage because I wanted to see the base of the lung. I also wanted to see the diaphragm. Here, I mentioned this retractor. Here's a retractor over here that you cannot see in this image, but that retractor is a Wheatlander, and it's just holding some structures apart so I can look up inside and I can see the right kidney. After I've done all of this setup here, and I'm going to show you in a little bit, sort of show you the process, I will take many of these out of place structures and I'm going to put them back in place. That's all done on the computer because I don't want students having the idea that this was the correct position of this arterial tree. So I'm going to move them back to the right position. All right. All of that preparation was getting me ready for filming. This is one of my filming setups. In this case, I've just hung over here a femur, that's the bone of the thigh. And you can see it's suspended from this device over here, which is spinning at a very slow rate, and I'm taking pictures of it. So obviously this is called photogrammetry and can be taking many, many photos, anywhere from maybe 400 photos to a couple thousand photos, depending upon the complexity of the model. I think what's more important than just there's a camera in front of this is the lighting. So I have about 12 lights in this particular setup, and it's not just front lighting. The front lighting is important because I have to get rid of the shadows, but because these models are very three-dimensional with parts that are sticking out all over the place, from a front view, I'm actually looking at some of the structures that are even posterior, they're behind. So I actually have to get lighting from behind as well when I'm filming. So these lights are actually coming in from behind. It's hard to tell from this picture, as well as in front. And you see I have a flash on the camera because sometimes I'm looking inside a cavity. And when you're looking inside a cavity, you really can't see in there very, very well. So this camera is on a post, and the post makes you think that, oh, the camera is totally stable. But reality is I'm actually hand holding this camera and just using the post for some stability. And I'm moving it around constantly for every picture, every of the 2,000 pictures, moving this camera around because I have to get the right angles constantly. And I'm also, because of the depth, I'm constantly changing my, my focus. That's the filming process. After the filming process, I begin processing and I get this lovely looking mesh, which is three-dimensional. I can rotate that around on the screen, and then a texture that overlies that mesh. To give a concept of the size of how that texture, this is a 16K image. I would use a 32K image, except my computer can't process it. It's too big. What is a 16K image? A couple years ago, people got excited about getting these 4K televisions. And now if you have a lot of money, you might get an 8K television. Nobody has a 16K television. So I feel like I'm future-proofing to the best I can with these large textures. So this gorgeous looking mesh here is a bit of a non-reality because this process is filled with potential pitfalls. So during the whole process, and whether it's during the processing or the post-processing, there's a lot of fixes that need to be done. And so here's a sort of a comparison. Some of these fixes were done during processing, some were done during post-processing. So let me focus you on this image to the right. You can see there's a couple of retractors in there. These retractors, if I had not done the fixes, then this retractor you can see is sort of just blending in with the small bow. And this retractor doesn't even exist. It's blended in with the ascending colon. And after the fixes, you can obviously see them a little bit better. You might also notice that there's a blue suture here that's holding this retractor in place. And there's another blue suture down there. And so those don't exist in this other image because I've gotten rid of those. Those are not important sutures. They would be distracting when you're looking at the final model. You can also see I've changed some of the colors around with post-processing just to make it look a little bit better. Embalmed cadavers typically lose a lot of their coloration. This is an interesting situation here. So part of the problem with the filming, like I'd said, is I have to hold everything out in some sort of a position when I'm filming it. So I want to focus your eyes on the red circle and that fuzzy line that's right there. I'm going to play this as a video in a second, and I want you to watch as that fuzzy line actually moves. Okay, so that's a wire moving across. And you can see it's not a really good view of the wire. So the problem is with photogrammetry, if you have some structure that you're filming that has low contrast, so that's wires, sutures, of that nature. The computer programs, the software has a hard time reconstructing things that have low contrast. And so it tends to do a poor job of creating them. And that's why you only see partial of that wire. But if you've been seeing the awful view along the whole sides here, all of these little lines here and here, all of those are the computer's best guess of where that wire could be. So I have to go in post-process and repaint all of this and remove all of this junk. Very time consuming. Over the past couple of years, I've managed to just keep increasing and increasing the number of cameras I use, which means increasing the power of the computer that I use. So I have a lot less of that artifact now than I used to have. I still definitely have the artifact, but that's one of the many workflow challenges that I might have. And now the models will look like this. So this is a medical holodeck model, obviously. And so when you look at this, you don't see those lines, that artifact all over the place. That's all been removed. This particular model, you don't see any sutures in there. That's been removed. There are a couple of retractors, but I don't think you see them in this view, in this particular model. But again, some of those I will remove, some of them I will keep there. And then the last part of the process is adding all these annotations. And this was a short and brief, exposition of my work. I want to thank the Willed Body donors who make Medical Holodeck Education Resource possible. And are there questions?
Thank you, Evan.
You're quite
Great
welcome.
insight. Questions from the audience?
I have a question.
Yeah.
Yeah, thank you for the great talk. Really amazing to see how much effort you took and how much detailed work you've put into these models. And that also leads to my question. Do you think that current and future developments will enhance the quality of the results just by computer processing, and you don't have to do so much manual work? Do you see that technology goes this direction to really make things easier to create accurate models now and in the future?
Absolutely. There's many ways you can answer that question. So someone had mentioned Gaussian splatting. That has some potential also in making the models potentially smaller. That's something I've been exploring recently. The power of AI is amazing. I'm concerned, though, that what you can and cannot create with AI. And I'll give you an example. I used Midsummer Journey. Is that the correct term for one of the AI art programs? So I used that a couple of years ago, and I told it to create me an anatomy textbook. And it did a wonderful job of creating the concept of an anatomy textbook. It took whatever images it came from. They mostly seemed to be from about the 1500s. And it created something with bizarre shapes, but there's no question, if you looked at it from a distance, it looked like anatomy. And then as you looked up close, it was completely non-realistic. It was abstract art at the best. So that's what my only concern with using the AI, which is it's going to try to create something that's not there. Whereas anatomy, there's two things about anatomy, and probably most of you know who are physicians and anatomists. Number one is probably the most important thing. It's not about what's in a textbook. Most anatomy is not artifact, it's anatomical variance. So the AI, putting it another way, is not really going to know where the actual anatomy is from an individual or even from the cadaver that I'm filming at that moment. So I think there might be a lot of post-processing that has to be done anyway on my part. However, I don't know that. I don't have a crystal ball to know how good the AI is going to wind up being for that. But also some of the software is getting so much better. So the models that I'm currently making, they have much, much better recognition of blurry areas. So I have 1,800 photos in a model I just filmed. And part of those I've had to bring my depth of field down to like a sliver, a centimeter. Yet the software is able to take care of that. It's able to just recognize that sliver thin area and only use that, so I don't have a lot of blurry overlays. So that's really, really good. There are other technologies there that hopefully can speed things up, because I have a pretty hefty computer, but it's still 12, 20, depending upon hours to process this. The other thing that I just mentioned was I have these future-proofed technologies, like these 16K images. But the reality is, if I take a look at my images and I took a look at the models that you see when you're using Medical Holodeck, there's tremendous room for improvement. The processing itself reduces a lot of the resolution, reduces a lot of the ability to tell one structure from another structure. So there is a lot of loss there. But again, I'm constantly trying to stay up with what is the latest, greatest to try to improve that.
Thanks a lot.
Let me read question from Gabriel. Awesome job. What software did you use for 3D scanning and processing images?
So part of that I can answer, part of it I can't. So there are a number of pieces of software I use. Unfortunately, the one that I'm using right now for Medical Holodeck is proprietary, so I can't really talk about that one. But it doesn't have to be proprietary. There are some really good pieces of software out there that one can use. In fact, I have some software now that I got on my phone. I mean, I want to take that and take a look at a cadaver with it. So, it's just really modern tech that can potentially make my world a lot faster. So I'm sorry, I can't really answer the exact question on which I'm currently using.
Okay. Do you have other questions here from the audience here?
Yes.
Thank you for the talk. Do you only work with formalin cadavers?
No.
Fresh frozen?
I haven't used the teal cadavers. I mean, I've used them personally, but I haven't filmed with them. And I don't use fresh frozen. There's a reason behind that. I don't know if you've used them. There's a process of degradation that happens. You think, oh, it's a fresh body. Let me freeze it. Let me take it out of the freezer. It's pristine. It's not. The degradation happens rapidly, and even while it's frozen, it degrades. Part of it may be that you're taking, the vasculature and you're bursting it open potentially. So you get a lot of leakage in the skin. It doesn't look as good as you might want it to look. I will use some soft embalmed cadavers as well. That can look, it has better coloration. So a glutaraldehyde as opposed to a formalin fixed cadaver can look much better. But I can't use the glutaraldehyde for these. So the models that you've seen in Medical Holodeck, these take a year to produce a model, like to produce the whole data set. And the soft embalmed won't last that long. And even the teal sometimes will and sometimes won't last that long. And the problem is once I start, you don't want to have a loss of a cadaver, because it's so much work, and to lose it partway through, it's pretty awful. So I definitely trust the regularly embalmed cadavers the most.
Have you tried using dental scanners, particularly in cavity scanning?
Yeah, absolutely, on myself. That's sort of a joke, but I do not have access to a dental scanner. It is a great idea to use something like that. And that is what we're looking at next, because we're going to be looking at maybe endocavity type of scanning, whether it's a dental scanner in there or an endoscope. The idea is to get in and around a cavity and see something up close and having it rebuilt. I haven't done it yet, but that's definitely on the to-do list for some of the more difficult internal dissections.
Yeah, I also have a question. You are using the software also for your own teaching. Can you tell us a bit about the setup or your experience?
I would love to. Do we have 2 or 3 hours left?
Yeah.
So I use this in many respects, or many different groups of students. So I'm going to jump right back to the very first slide, if I can share that just for a moment. So the very first slide of this presentation that's coming up in just a moment, this is a particular teaching. This was done with Medical Holodeck, as you can see. in the background. It's a little chunky right now, but it will come up. So you can see back here, hiding behind there, there's one of the models that's in Medicalholodeck. Yet the one up front, that's one of the joys of Medicalholodeck is I can import my own things. So this is just a regular bony pelvis. It's not computer graphics. This is an actual pelvis. And so the people you see in the foreground, these are two Eurogyne residents. And what they were doing was they were taking a look at the bony pelvis, having a conversation about the pelvic floor, and that's the artwork you see. So they drew that using Medicalholodeck. And they compared that to the cadaveric anatomy that you see in the scene. Unfortunately, what you don't see, which is off to the side on the left, is a PDF that's also in that environment. And the PDF has a series of images that are laparoscopy images. So then they're discussing what are they seeing in those laparoscopy images, and let's see where that would actually lie in the cadaver, because when you're doing laparoscopy, you have to know your anatomy very, very well. So again, this is residents thinking about what the anatomy is, using imaging, using the cadaveric dissection, using a skeleton. So it's sort of a one-stop shopping for thinking through the anatomical process. So that's one use case. Here's another use case that may come from left field a little bit. During COVID, when students couldn't be in the anatomy lab, I would say, here, have one of the glasses, take a look at this, or one of the headsets, and they would take it home and they would just start looking up their anatomy. They had my structures lists. They had our lectures. They would look through it and start finding the anatomy. And I will tell you that, and this is anecdotally because I don't have data to show it, but I will tell you that the students who used this instead of learning on the cadaver did just as well on the exams, which was a little disturbing because I don't want students to not come to class and dissect the cadaver, because there's a lot of lessons you get by working on a cadaver that we're not quite there yet with this virtual use. I'm also currently, I have 2 different campuses that I teach on, but I don't go to the other campus. It's 2 hours away. So they have like 14 headsets. They have Quest 2s and Quest Pros. So I will sit in my office and I will give them lessons. And we'll just talk through the anatomy. Their program is case-based. So if they have a case on carpal tunnel syndrome, we'll just sit there and talk about the carpal tunnel. I will also, for them, maybe have a PDF that's up on the side in the room where they can go through a series of questions, and I don't have to be there. It can be self-directed. And then the last one along those lines, or actually there's 2 more. Sometimes students will just sit in the library, 2 of them in a headset together in the Team XR, and they'll just talk. And they'll look at the anatomy and they'll discuss the anatomy, and they'll just come up with questions on their own. They'll just quiz each other. And that's a beautiful thing when I see that happen. The last one, which is just popped out of my head, but there are many use cases for this teaching. And so students come up with some of their own, and we'll come up with some of our own as well. Hopefully it answered some of your questions about that.
Thank you so much, Evan. I think, do we have more questions? Tommy here? Is there? No? Good. Thank you for awesome presentation. And it was amazing to see how much work and how much passion is in each of these models. I mean, that's always amazing to realize when you have it in front of you that this is really, really, really cool 3D data for anatomy study.
You're quite welcome. All right. Thank you.
So let me introduce you, our last presenter. It's Professor Dr. Marcus Holling from University Hospital in Münster in Germany. He is, I would say, one of our earliest users. I mean, today almost all of the speakers were very early users, but I think Marcus was number 3 or 4 back in 2018. And he's still using our application, so especially proud to have him here, and he will let us know an interesting case report from his field, from neurosurgery.
Yes, Thank you so much, dear Chris, dear Dominic, dear Tomek. Thank you for the invitation and for having me here. And I would like to pick up the ribbon for the educational purposes, because that's what I'm doing since, let's say, 18 years now. And I'm fascinated about neurosurgical education. And of course, since 2018, I think, we are in contact. And yeah, and it's a very happy to hear all these great talks today. And I think there have been a lot of, let's do it like this, some concerns even in 2018 when we started, and I showed you this picture in the last year in the same manner, because when you start with a new idea, everybody's asking you, oh, are you an idiot? And I said, no, not really, perhaps, I don't know, but perhaps a little bit, but I'm quite interested in this technology, and I believe in this technology, and I believe that in the future is this technology. And well, and now we have 2024, still the same question sometimes. But actually, I think we made a good way, and I will tell you why, and I will tell you what we did. You've heard some really great things from Bonn, and all these things are coming together now. And I think Medicalholodeck, and especially these technique options, are quite tremendous. And I think we will have a tsunami in front of us, and you will see here the new idea of extended reality. And if you look at PubMed, at one of the major resources for medical science, then you will see that there are up to now 1.164 thousand publications with extended reality. And believe me or not, but I think the future is an exponential climb of these numbers, because what you have heard today about the clinical practice, about the clinical details, what you can use, not only Medicalholodeck, but the whole technique, you will see in the future. It's what we will do. And the potentials and the options of these virtual reality or extended reality at all, I would think there are three major tasks from a surgeon's perspective. You've heard from Galal and from Mark. It's a very easy strategy planning. It's very easy 3D assessment. You can hear, and you will hear from myself, as it from a teacher's perspective. You can see the patient-specific anatomy, and that's the major difference between learning from a book and learning through all these atlases. You have the patient-specific pathology, and that's what you need in your daily practice. You don't have any effort if you can look into the book, and there you will see again and again and again the same picture, but the patient will change, and so you need the pathology-specific and patient-specific anatomy for your daily use. And you can see it from a patient's perspective, and you've heard from Galal that you can use it for follow-up, and you can use it for patient education, and we have done it in the same way. But today I just want to go into detail from a surgeon's and from a teacher's perspective. And in the situation we are actually, let's say in Germany, but I think it's nearly the same way around the world, that we are in a competition for the students and for, let's say, for best evaluation. So the distribution of not of my salary, but of the money we will receive from the teaching is estimated from the evaluation of the student. So I can tell you, and you've heard it from Jan, from Bonn, you will, just one tip for you: if you want to accelerate your evaluation, use virtual reality. I don't know why, but it's really a great thing. And you will hear all these things, all these comments, all this feedback from the students, that they love it to see anatomy again and to see these pathology again with a view from the virtual reality perspective. So as a discipline like neurosurgery, well, we are. I have to do it's easy to do a little bit PR for the brain, because it's a very fascinating organ. But nevertheless, even our subdiscipline has lost some of major indications for surgical interventions to, let's say, to the radiology interventional colleagues. And so we are trying to do hands-on courses and especially to show our discipline to all these young colleagues who perhaps do not know what they will do in their future. Especially if you have a look, it makes sense. It makes sense to present your subspecialty. Let's be it surgery or not, but to present your subspecialty for these students. And so I cannot emphasize enough that it's much more important to do a good job at this time. And what we try to do in Münster to fascinate young people from neurosurgery, it's on a very short time frame. So we are in the 8th semester, so the students had 4 years of medical school, and then they have 4 hours neurosurgery. And in this 4 hours, I have to compete with all other subdisciplines. And so we try to do our best, and I try to implement virtuality there. And I can underline what Jan have said. The evolution, I mean, the evaluation of these sessions is great. So it's really good. But on the other hand, if these students get our residence, then we have to say we have to keep their faith. We have to keep their faith in us that we have enough number of cases to fulfill their catalog of surgeries they have to perform before they get into the board examination. And so even under COVID-19, it was very bad times. The numbers going down and the numbers went down. And so we had to think about other options, how we can teach them. And as this paper in World Neurosurgery showed that post-pandemic, there was a paradigm shift to telemedicine, of course, and teleeducation. So you need an option for if you cannot go to the patient into the patient room, so you must do something. You cannot do nothing. So and this is something where we started to think about how we can show selective cases. For example, even aneurysm surgery, cerebral aneurysm surgery becomes quite rare in neurosurgery due to the other subspecialties. And so we try to present our residents what they can do and what they can see and how they, let's do it like, okay, sorry, I'll go back. What they, not what they miss, but what they can, how we can show them what we can do interoperatively. So we try to put my window away. But nevertheless, I think what you have to see, you can see. So let's go to crime scene investigation in neurosurgery, and I prepared one case which I kept in mind, which was a very fantastic case to show the opportunities of virtual reality. And this was during the COVID-19 lockdown in a rural area near to our university hospital. 2 masked men robbed a oil station, and the attendant had been hit by an axe 2 times. So at first at the front head and then into the head. And I was on call, and then I thought, oh my goodness, would it be something like this? But no, not really. So the patient showed up in our emergency room. He was GCS 15, so this is the best you can have. So he was talking. He could tell us everything what has happened. The police was standing there, make the notice, and oh, very interesting. And he said, oh, I'm a little bit of headache, and you could see a cranial wound, but no severe bleeding. And he said, well, I have a numbness of both feet. And at this point, you can ask a student, where must be the pathology that you have a numbness of both feet? That's very rare. That's very difficult. And well, I was waiting for the scans, and then the first what we saw was this X-ray, so the scout of the CT. And don't worry, this is not the X. What is inside the head? That's just the amount of the CT. But you can see there a lot of stuff around the head because there was blood, and then finally the CT was there. And then you look at the CT and you say, oh, well, no big bleeding. Well, everything's fine. But this picture is a little bit like this. The more you look, the more you see. And if you look in detail, at the top, at the high frontal part, you will see here a little bit of epidural blood, and you will see, and you can see it in the bone window much better, you will see this bone flake directly under the skull. So what has happened? You will see it later on in the reconstruction, but these are the pictures you will see in the emergency situation. So, and from these pictures, you have to make a decision in, let's say, 3 minutes, which direction the patient should go, on the ward, in the OR, wherever. And what we did, because obviously there's the big venous vein, it's the sagittal sinus. It's very, very critical if this one gets injured. We did these pictures, so there's an angiography of the venous system, and you can see that there's a congestion of these very big veins. So these veins over here should have the diameter of this over here. So there must be somewhere a congestion of the venous system. And our thought was, due to this congestion, the function of the sensitivity, which is coded over there, of both feet, and that's the only reason where it could came from, must be the reason for the neurology. And so if you try to educate a student with these pictures, you must be very, very good if everybody should understand what you have spoken to him. Now, and I will show you now how easy it could be. So this is the head of the patient, and you can see everything. We look on front, and at first we can have a little bit more look at the flake fracture here at the front. That was the first hit, and then here has been the second hit, and due to the fact that everything is a little bit too small, we can enlarge it a little bit. Hopefully I've done it. And zoom in. And I choose this windowing because you can see now the vasculature in the same manner like the bone window. And now with zooming inside, you can see that there is this bone flake. Due to the impact of the axe, this bone flake get onto the sinus, but there was no injury of the sinus, but this sinus has been here compressed. And so my major task was afterwards to put out these flake. It's everything, but you have to understand it. And so you can go with the students into the head. That's what I've done, and then you can tell them a little bit about the normal vasculature, anterior cerebral artery and middle cerebral artery, and everything. What's nice and what's interesting, and what's very individual in every case. And then we can talk about what will I do during the surgery, and then I used the pencil and did a little maneuver over here where I said, well, let's include the wound which has already been there from the axe. And then I want to distract with retractors the skin to both sides so that I have an approach to the sagittal sinus. And I have to be aware during the whole surgery that these venous structure might bleed with a very severe bleeding. So I must have a good approach to this. And now I try to simulate this approach with this mask tool. So I can drill away with the same size of our drills. I can drill away the bone so that we have a very nice look on this flake. So this was what I did, the burr hole over there, a burr hole over there, and then with a special drill to drill the rest of the bone away so that we can directly look onto this flake and the sinus which has been patent, thank to God. And then now I simulate to take away the flake like this. And afterwards, I put in bony cement, and we can simulate this in the same manner. Look, and now I close everything again. Yeah, and now we can go into the skull again, and then you see, ta-da, the bony flake is away. We can go with the students inside, and ta-da, it's away. And that was that was look like the pictures we did post-operatively. Unfortunately, without any CT angio, but the patient did extremely well. So there were no major concerns. So that was very, very easy. It took me, let's say, 2 minutes to do these manipulations. Very, very easy. The impact of the knowledge for the students is tremendously. So that was very, very interesting. And the student gave me this feedback. And yeah, so since then I used this case. So from my perspective, VR in neurosurgery is, and you can well remember what Galal said, it's feasible, it's reasonable, it's multidimensional, and it's reusable. I had to do once this case, once a time, and can use it for the rest of, let's say, my life, okay? And in Münster, compared to Bonn, we have to do some work. But yesterday I passed the talk to our data security officer. So now everything will get up speed. So we do it for our local network. We will build up now local infrastructure, and there are a lot of hospitals, so other departments who are interested in this technique. And I think so we can improve the quality of what we do for our patients and what we can do for our students. So thank you so much. And that's not virtual reality. That's the real picture from my office in Münster. Thank you so much.
Thank you, Marcus, for this really very interesting insight. I mean, that's also the first time I saw that case. That was really amazing. I mean, so let's jump to some questions from Mr. Ahmadpour. Well done, dear professor. I was thinking during your demonstration about the question that what this kind of technology is very expensive. How can we use such technology in developing countries?
Well, I think that's the question, not only to me, it goes up to you, but from my perspective, and I think we already had an answer like this or a question like this, because I think what you need obviously you need radiologists who can make the the pictures. So you need a CT scan, MR scan, whatever you want. And afterwards, of course, you need a lens. So that's what it is, and you need a license for the software. And I think I'm not quite sure what you are interested in, but it's a question of time, because I think the software might be the problem, but the hardware won't be the problem, right?
Yeah, well, it's interesting question, because in the way or in the perspective that the software is also not the problem. We just had recently feedback from also a neurosurgeon, but I think from Syria, who just sent us the feedback that he is using the software for education and other purposes, for visualizing and understanding neurosurgery cases better. And the software is very feasible in price, also for developing countries. That's also what we feel like. And from hardware perspective, it changed a lot since 2018. So the performance of devices like MetaQuest 3 is sufficient for rendering DICOM data. So you don't need any computer anymore. So it changed dramatically, and that's also why we are all excited where it goes from here. I mean, we saw Apple Vision Pro. We see where the technology goes, or how the performance of the technology goes, and that's why it just gets better. So also what Marcus showed, I mean, he showed the system together with a laptop, so he has high performance. You need high performance to really stand into the brain or into the skull of a victim, but you can also keep it in one-to-one size, and then you're very fine with MetaQuest 3 at the moment. Do you have other questions from the audience? Evan?
Yeah, if you on your scan, when you were removing the piece of bone that was a fragment, if you windowed and changed it so you really only saw bone, and then you removed the bone, does that also remove the surrounding tissues, or is it really just removing a visible tissue at that time? Does that make sense? So when you draw everything back up, and then you showed the superior sagittal sinus and the vasculature.
Yeah. You mean during the video or during reality?
No, during the reality with this software, with Medicalholodeck.
I think that's a question Dominic can answer.
It only removes the visible.
The visible,
part.
okay,
So when you
okay.
filter, you only look at that visible.
Great,
And
thank
you
you.
put the back, everything else. Okay.
So you can window visit what you want to see, and then really, what's the name of the tool? Masking. Yeah, it's a masking tool, and then you also can invert it. So if you mask some part, you can invert it, you can take it apart, or you can really, that's the main idea or main goal of this tool.
And you can use different layers, so not only once.
Yes.
And you can use all these setup parameters, which is very, very useful, but it took time. So it took time.
Yeah.
We have other questions.
Thank you for the talk. How did you manage to implement the system into the hospital, like financing stuff and regulation?
That's the major question. And let's say I have only a very individual answer. So the hardware you have to buy, the software you have to cooperate, and let's say the data protection problems will be everywhere, let's say with different nuances. And it's a question how you deal with the patient. For example, they have to give me everybody have to give me a signature that I'm allowed to use these pictures if we can see them, if the students can see them also. So that's let's say that's only you have to be at the forefront, and you have to fight every fight again and again and again. And that's what I want to tell you. If I showed the first slide in the beginning in 2018, in 2024, the problems have been the same the whole time. Only people changed, and then you can much easier. Some people understand what the impact of this will be, and some did not. And so, well, you have to keep on fighting. But there's no solution for everybody. It's
Yes.
very, very individual.
Yes, but what from a production perspective is that data protection issues are going to be solved by technology. So it will maybe take some time until it's passed through the hospital, but I mean, Medicalholodeck is built in a way that all these questions can be solved. And now also what Marcus just said is even or also in Bonn, I mean, we have now a lot of experience with German hospitals, and we did even build some workarounds for example, what Dominic just did with his team is, for example, like a peer-to-peer data uploaded to standalone Quest 3. So this means you do not share the data on any server anymore, and that's also where it goes. You know, it's moving very rapidly at the moment. When we think back in 2017-18, there were like light towers, clunky headsets, and so on. And now it's 2024. Now we are going into a way that we have peer-to-peer data uploaded directly from the PAC system. So all these issues, I mean, once I heard from a German politician that data protection doesn't stop innovation. Well, it doesn't stop innovation, but it just makes it maybe a bit slower. But still, the speed is so high at the moment that, yeah, what is a year? You know, what is half a year? That's enough to, and it's also important to do these things very clean and clear. To approach these issues, data protection issues, which will be just more and more important because when we see where we are heading to. So that's it's in fact it's a solved problem. It just needs to be taken into account to have 6 months, 12 months for the process to get the right audits done by the positions in the hospital. We have another question. Do you think that a solution like Medicalholodeck can be implemented as a standard in emergency treatment? given the speed of data loading and the practicality and speed of interpretation?
Well, I think the for emergency treatment, well, the problem is I've learned to interpret these data on a 2D base. So I've learned it 2D and I did it for 18 years. So for my personal, it would, or I don't need it in so much as perhaps younger colleagues need it. So I think the best thing would be if there's one colleague who is new and could use this technique, and there's an older guy who said, yeah, of course, look at the top and that's it. So I think to say that there is a must of having this technology in an emergency setting might make sense if it's feasible and if it's fast. You're completely right. If there's a need, I'm not quite sure. I think it would enhance the whole scenery, but I think it would be okay if there would be anybody who can see the picture without any technical stuff. But that's just for the emergency situation, because as I said, you need you have 3 to 5 minutes to make such a decision, and if such a technique could enhance your standing there, or if you feeling much better, then it's quite okay. But there should be no delay due to technical issues.
Another question from Guido. If you load a CT scan on Medicalholodeck, the name of the patient is omitted.
It's anonymized.
Yes. So that's what I also mentioned before. It's any data uploaded into Medicalholodeck, if it's on a tethered or standalone, the patient data is completely stripped away. So we are only working with imaging data, with the pure image data. Dominic?
Yeah, absolutely. So as soon as you import it, it's no longer there. So you cannot display it, you cannot type it, because it never existed when it's inside the application. That's what makes it kind of safe for a lot of things. But the safest way is to go to import from hard drive. And even then, so you cannot be RAM memory or whatever you would like to do to the application. It will be effectively not there anymore.
Thank you. Okay. Do we have more questions from here? If not, thank you so much. Thank you, Marcus. Very interesting presentation. And then we close the conference here. We have prepared some headsets if somebody wants to take a look into the application, how it looks like. We have Quest 3, we have Magic Leap 2, we have some other stuff. So thank you so much for your time, and I wish everybody a good day.